So, good evening, everybody. I, Dr. Monica Gupta, Secretary of Association for Obstetricians and Gynecologists, Delhi, welcome you all to this all-important webinar on hypertensive disorders of pregnancy. And this time, very aptly, we are co-organizing this with Gestosis India, which is the Indian chapter of the World Gestosis Organization and has been involved in the research and formulation of guidelines regarding hypertensive disorders. And we have amongst us the all-important president of Gestosis India Association, Dr. Suchitra Pandit, who has kindly agreed to co-organize this program with us. She's the chief guest of the program, and she would also be the expert in the panel, which will soon follow. So I would request now the President AOGD, our own Dr. Achla Batra, and President Gestosis, Dr. Suchitra Pandit, to please say a few words for welcoming our delegates and faculty.
Yeah.
Over
Thank
to you,
you.
Achla, ma'am, first.
Good evening, and thank you, Monica. And this program was long overdue. You know, this lecture was supposed to be in November, the first lecture by Dr. Prakash Mehta, and then this program was to be done in January. But because of the COVID, and first it was AICOG in January, which got postponed. So finally, we have this collaboration with Gestosis. I am so happy that we are doing this program with Gestosis India, and Dr. Suchitra Pandit is here with us. And hypertension, we all know, however we talk about it, there are always some gray areas which are never clear in our mind. And now we are coming up with so many biomarkers, and who other than Dr. Prakash Mehta to deliver a talk on that, and the panel later to clear the doubts which we have. So I welcome all of you. I welcome Dr. Mehta, our guest from Bangalore, Dr. Sharda Jain, our teacher of teacher and everybody's teacher, I think, and Dr. Ranjana, who is the chair of AICC North Zone, and a dear friend too. Dr. Pratima is there, and all others, you know, my colleagues, my friends, Rinku, Leena. I've known these people for so long, and they're all very dedicated people. And I think the audience are really going to enjoy and learn a lot from this. And I would like Dr. Suchitra, who's a co-chair in this program, to say a few words before we invite our guests. Yeah. Dr. Suchitra?
Yeah. Thank you very much, and a very good afternoon to all of you. First of all, at the outset, I'd like to thank Dr. Achla Batra, President of the AOGD, for agreeing to do this program with the Gestosis India Association. Very, very, important topic, and I'm glad that the way you've set it out, with one person speaking, and then we are having a case-based discussion. It's so very important because we all know that after postpartum hemorrhage, hypertensive disorders are the major killer. And this is something, if we have focused group discussions every now and then, I'm sure people will learn how to manage the hypertensive disorders. And, we want to see those maternal mortality figures coming down to as much as possible. I'd really like to thank Dr. Monica Gupta, also Secretary AOGD, who's working with Dr. Achla Batra to, give so many interesting programs, because I do follow the AOGD programs and the AOGD bulletins which keep coming. Excellent work that has been done. I'm also very, very thankful to Sharda Madam. She came in for my program 2 days back, and today she's there. It feels wonderful when a person of that stature, that nature, and somebody who's been a crusader for so many important social causes is here to give us our blessings. I think, thank you very much, madam, once again. And of course, happy to see Dr. Ranjana Sharma, who is AICC North Zone Chair. Hi, Ranjana, very nice to see you, and nice to see Alpesh. And of course, Dr. Mittal, who is again, I've been a friend of hers for a long, long time. And it's always nice to see her because she's involved so actively in so many, academic programs. Lovely to see you. And to see my friend, Dr. Prakash Mehta. And of course, I'm going to say that Jyotsna Suri and Gariba Kapoor, I'm waiting to hear that panel discussion, because it's important. You have excellent panelists, Girija Wag, Anjali, Devendra Kumar, Renu, Leena, Sridhar, I'm Shruti. I mean, they're all going to be there, and we are going to try to get out all the technical problems that do occur with people, and when you're managing a case of hypertensive disorders. And I'm sure at the end of the day, the viewers are going to be benefited. So once again, friends, thank you very much for being there, and for being for being so attentive to this particular session, and that you've gathered in large numbers. Thank you so much. Thank you very much.
Thank you, ma'am. I would now request our guest of honor, Dr. Sharda Jain, who's the founder and secretary general of Delhi Gynecologist Forum, and has been teacher of teachers with the experience of more than 2 decades, and a dedicated worker in field of gynecology, our advisor. Welcome, ma'am.
Monica, enough.
I would like you to
Yes.
please say a few words, ma'am.
Yes. At the outset, my special thanks to Dr. Achla Batra and the team. And it's a pleasure that I could see all my friends, Dr. Pratima Mittal, Dr. Jyotsna, Dr. Ranjana, and so many stalwarts who had been heading or who have been associated with Dystosis India Association. And I'm pleased to see for the second time in a very recent past to Suchitra Pandit's program. And I think she knows that I admire her as an orator, as a teacher, and I enjoyed when she was a past president of FOGSI and her love for Dystosis. And I think, at that particular time, all salutes to her that, 130, more than 130 sessions, she went to different parts of the India to train and teach about hypertensive disorders of pregnancy, because all said and done, maternal mortality is our aim. It has to come down. Our focus has been on the PPH, but the equal focus has been there on the hypertensive disorders of pregnancy, because they stand tall after PPH. And these hypertensive disorders over a period of time, since the time we were students and we were teaching, there has been quite a shift in the change of the costume of the hypertensive disorders of pregnancy. And I think our understanding has become very, very clear. Earlier, we knew a couple of things as far as hypertensive disorders were concerned, that there is a vasospasm, there's a decreased placental blood flow, but a whole lot of changes have come now. I think each and every young person should definitely know about it, what is happening. What I can say is that, when we were in medical college, things were very different. Now in the private practice, I don't find eclampsia disappeared, but then now prevention has become our focus. And I think today's deliberation, especially by Professor Mehta, is going to see on that particular aspect. And I'm very waiting to hear Professor Prakash Mehta on this. And my sincere appeal to each and everybody who's listening this particular thing today, that Dr. Suchitra Pandit wishes to work even beyond as a FOGSI president. She wants to represent us in FIGO. She has got so many flagship awards as far as the FIGO is concerned. And I think, she should be a candidate where your choice should lie. And this also gives me greetings and best wishes to other people also, who also want to make a name and become a part and parcel of the FOGSI as an association. So I wish them all good who have been there in this particular symposium organized by Dr. Achla Batra and team. Thank you, Dr. Achla Batra again.
Thank you, ma'am, for your kind words. I would now request Dr. Ranjana, please, to give a few words of wisdom. She is the senior consultant at Apollo Hospital. And more importantly, she's the chairperson of All India Coordinating Committee of RCOG North Zone, and a very important executive member of AOGD. Ma'am, please, over to you.
Thank you very much, Monica. Thank you, Achla, Jyotsna, Monica, and the whole AOGD team for giving me this opportunity to share the platform with such, stalwarts like Dr. Suchitra Pandit, Dr. Sharda Jain, and so many people in the audience, Professor Mehta, Pratima Mittal. So many people are here. I'm very glad to share the event with all of them. And as people have already, Dr. Sharda Jain has already discussed, it's such an important topic. As we know, AOGD has always been at the forefront of all the academic activities, and you have taken this, which is such an important, cause of maternal mortality. Not only maternal mortality, it is a significant contributor of perinatal mortality and morbidity also. And if we can predict, why not? And as Suchitra has already come out with such a good, scoring system for, clinical, risk factors. So, we can assess before we get the lab investigations and ultrasound findings. So prediction is so important because you can actually change the outcome if you can predict and prevent by starting aspirin on time, and then early detection of the disease. So actually it's in our hands to improve the mortality and morbidity. And I really congratulate you to take this topic and head on. And very good. I'm waiting for the lecture on biomarkers, followed by an excellent panel discussion with, so many excellent panelists. Thank you very much, and wish you good luck. Thank you.
Thank you, ma'am. So without wasting any more time, we straight away head on to our scientific program. And I would now like to invite our own Dr. Pratima ma'am. She's been always and will always be our chief advisor.
उनका सारा पढ़ने की जरूरत नहीं है, please.
Okay, ma'am. Just to inform everybody, Dr. Alpesh was also supposed to chair the program, but due to some unavoidable reasons, he's not been able to join us. So over to you, Pratima ma'am, to please introduce our speaker for the first session on biomarkers.
Monica, Monica,
yes,
just before we start, one minute, can I just talk half a minute?
Sure, ma'am.
I wanted to actually thank AOGD and Dr. Achla Batra and Dr. Sharda Jain. I didn't say that, but I'm very touched by the fact that you all have nominated me. Thank you so much for that. The entire AOGD.
Good luck
with the blessings. Thank you so much.
Okay. Hello. Thank you, Dr. Achla and Monica, for giving me an opportunity to invite such an important, speaker, and it is such a prestigious moment for me to invite Dr. Prakash Mehta, whom we all know that he is the chief of the division of the fetal medicine and head of the department of Obs and Gynae at Bhagwan Mahavir Jain Hospital, Bangalore. He has got postgraduate fellowship and post-PG fellowship, and people are really, keen to join his FNB course. When I ask the people in number, where will you like to go? So his center comes, in the topmost top 5. And then he has got very numerous articles in various journals. He has been the president of Society for Maternal Fetal Medicine India. He's contributed chapters on maternal and fetal medicine in many, many books, delivered oration in the field of maternal fetal medicine, and of course, past Joint Secretary FOGSI, and he's got the Best Teacher Award, Ambal, in 2019, Best Teacher Award in Bangalore Society of Obs and Gynae 2020, and Lifetime Achievement Award of BSOG 2021. And on top of it, he has been, we are doing many courses of the critical care in obstetrics from ICOG with him, and he is running a critical care obstetric center in his institute. And I think from all over the, south of the Bangalore and north of Bangalore, from every nook and corner, the serious cases are just being, blindly referred to him. Everybody just says, take the patient to Dr. Mehta's place, patient will be saved. So that's how I feel. So most welcome. Dr. Mehta will be talking about the biomarkers, and we have been talking about gestational scoring and all those are the clinical things which we are thinking. But now with so many biomarkers and early detection at the early 11 to 13 weeks, I think we can prevent, even we cannot prevent, but we can manage the patients even for early onset preeclampsia. And Dr. Mehta will be talking about the biomarkers in preeclampsia. Dr. Mehta, please.
Yeah. Thank you very much, madam. I'm really humbled by the wonderful words that you have spoken. You, Dr. Sharda Jain, our Dr. my very close friend, Dr. Suchitra Pandit. And of course, I have to thank Dr. Achila and Dr. Jyotsna for inviting me here this day. I'm sorry, I was supposed to give this talk sometimes in November, but I was in a small town at that time. And, the internet problem came in and the talk got postponed. So here I am today. I'll just share the screen, please. Okay, is my screen visible?
Yes.
Yeah?
Yes, it's visible.
Okay, thanks. So today we'll be, in the next half an hour or so, we'll be speaking on the role of biomarkers in the preeclampsia, both for prediction as well as for prognostication. We know that some dangers are very well seen and it is very easy to identify them, whereas some are really hidden. This gecko within these flowers is hardly seen. To identify these kind of hidden enemies, we definitely need some kind of help. And biomarkers are one of that who may help us in both predicting as well as prognosticating the outcome of preeclampsia. We all know that preeclampsia is not a simple disease. Maybe it is not even one disease, it's a syndrome. And we also know that the early preeclampsia and the late preeclampsia may be a totally different cup of tea, having probably not much relationship also to each other. So because of its ambiguous presentation and unpredictable progression, I'm sure all the seniors over here would have definitely vouched for the fact that you get patients who have just a blood pressure of 140/90 and the next day they come with convulsion or renal failure or a severe accidental hemorrhage. So how do we identify which patient this kind of thing is going to happen? Before, like Madam Sharda Jain said, once upon a time, the preeclampsia concept was very simple. We are told that there is a preclinical preeclampsia, then an overt clinical preeclampsia, and then finally it would result in eclampsia. We now know that this is not the truth. A lot of changes have occurred, and we also know that 40% of the women only exhibit both hypertension and proteinuria before the development of overt preeclampsia. And 22% of the women who even develop eclampsia may not have proteinuria. So here is the confusion. The problem of atypical preeclampsia causes a lot of confusion as to how do we diagnose and how do we go ahead with that patient. Now, the riddle is also there because the onset and prognosis is different depending on the etiology of preeclampsia. We all know that it could be due to placental damage, it can be due to an altered angiogenic state, or it could be due to maternal susceptibility, including genes in the mother. Early versus late PE, as I already told, could be, say, different disease or different facets of the same disease, or may not have any relationship to each other. Therefore, this disease is a significant diagnostic challenge and requires a large degree of clinical judgment. Now, unfortunately, because of its unpredictability, it is often misclassified. You presume that this is a mild preeclampsia, and that is why the terminology is now changed to not severe and severe and not mild and severe preeclampsia, because there's nothing called as mild preeclampsia, and it is even misdiagnosed. Now, if I say that this patient has got preeclampsia, then my management becomes resource intensive. I need a lot of money, or the patient has to spend a lot of money. The patient has to spend a lot of time in the hospital. So do we have something in our hand which could help us to identify, yes, this patient could be having a problem and this patient may not have a problem? Now, again, unfortunately, the current method of monitoring preeclampsia is a 90-year-old care pathway. And we know the way the world has changed. Old may be gold, but still it is not as good as what it should be. Scores and biomarkers. These are the two things we get. We know that Dr. Suchara Pandit, through the Gestosis organization, has come out with a Gestosis scoring system. And similarly, we have many other scoring systems along with biomarkers, with or without either one of them, could identify women who are at low risk of developing complications. Now, once I know that the woman is not going to develop severe complications, it's very simple to manage her conservatively, and it also helps to reduce the anxiety all around. It is not just the patient who is anxious, even the obstetrician is also equally anxious. And if we have something in our hands, this could come down. I'll just give you a simple case which tends to really boggle the mind. This was a 33-year-old, gravida 5, abortion 4, with 30 weeks of pregnancy. She was referred to me as BOH with IVF conception. She had a high blood pressure of 160 by 108, appreciating fetal movements well, history of bilateral lower limb swelling for the last 2 months, no symptoms of severe PE. None of the symptoms were there. Her hematology and the biochemistry were essentially normal. The urine albumin was 1+, but there were 6 to 8 pus cells, confusing me whether it could be due to a UTI or whether it is really due to preeclampsia. So when you land up with this kind of a case, you need some kind of a help to identify, am I dealing with just a simple, maybe so-called gestational hypertension, or am I dealing with really with the preeclampsia? Is this patient going to be stable for the next 1 week, or is she going to worsen? So a lot of tough decisions are there ahead in this kind of case. How can we choose the patient? In a general pregnant population, here and there you have patients who have preeclampsia, and 1 or 2 among them are going to have a severe preeclampsia. So how do we identify from this group of patients who come to us? So therein steps in the role of biomarkers. Now, when we talk of biomarkers, we need to answer a few questions. Why? How? Do we do a universal screening, or do we do a targeted screening? And are biomarkers good for early or late onset PE? Now, there are many biomarkers, and they come from the 4 major hypotheses that we have currently for the preeclampsia. That is placental or trophoblastic hypoxia, vascular endothelial injury, oxidative stress, or immune dysregulation. We have got biomarkers for each of this, and possibly there are so many biomarkers that sometimes we get confused as to what to use. Now, it has also been found that multiple biomarkers in combination could help us in detecting a high-risk patient and probably lead to a targeted intervention. So just as I already told, the biomarker could be for monitoring, for response, could be predictive, prognostic, susceptibility or risk. It could be diagnostic to identify that, yes, this is not gestational hypertension, but it is preeclampsia. And of course, ultimately, the safety of the patient has to be kept in mind. It facilitates early diagnosis, a targeted surveillance, and timely delivery. As far as early pregnancy is considered, it allows us to either rule in or rule out. What do we mean by rule in? When I say this patient is ruled in because she has got an abnormal biomarker, automatically my surveillance level is stepped up. But if I say that the patient is ruled out, the biomarker screening is normal or biomarker prognostication is normal, then my level of surveillance would definitely come down a bit. Now, I already told you there are many types of biomarkers, and there are many potential sources for biomarkers in preeclampsia. Placental disease, endothelial dysfunction, organ involvement. You could have biomarkers measurable in the circulation, or biomarkers are there in the urine, and there could be an RNA species, DNA, metabolites, proteins. So a whole lot of them. It's a whole specialty by itself. Now, coming to the screening, we have certain challenges. The challenges are feasibility. Am I able to do the test? Or if I'm able to do the test in a tertiary care center, would a person working in a smaller center, a 10-bedded, 15-bedded hospital, would they be able to do the test or not? And second important thing would be cost. Because we are in a developing country and cost constraints are definitely there in whichever type of setup you're working. in a tertiary care center or maybe in a government setup where you may be able to do the test free, but if your test is not very accurate, you'll end up admitting the patient, holding on to a precious bed, which could be used for a patient who deserves it better. Now, also with the result that comes in, I already pointed out that all-round stress could come in because you put her automatically into a high risk category, and then everybody starts getting worried. Also, we know that aspirin is a very simple therapy. It could very easily prevent quite a few cases of preeclampsia. But if I do a screening test and call the patient screen negative, which we know in medicine, nothing is 100%. And a screen negative patient may work out to only 60-70%. Then I'm rendering that woman ineligible for antenatal aspirin therapy because my test result is not correct. So these factors also have to be kept in mind before we adapt this test in a massive way in our practice. Now, why do we have to do biomarkers? We already talked a little bit about early risk identification. So you do a screening and identify this patient is at risk, or you do a risk stratification. I've got a patient who has already has some amount of hypertension, or I know she has got a lot of risk factors. The scoring is very poor. So I can do a risk stratification for that particular patient. And then finally, we go into the individualized patient management. I think we are moving away from an absolutely guideline managed patients to individualization of the management of the patient. And in no other disease as compared to preeclampsia, individualization is very, very important. So now the biomarkers can be used for prediction, it can be used for identification or the diagnosis of preeclampsia, or it could be used for prognostication of preeclampsia to identify that yes, she is preeclamptic, but is she severe preeclamptic or is she not severe preeclamptic? To identify that, we could use biomarkers. Now for prediction, we have a whole lot of them. I'm not going to go into details of them, but it could be from maternal side, it could be from fetal side, fetal hemoglobin, fetal DNA in the maternal circulation, all could give us a clue. For diagnosis of preeclampsia in third trimester, let us say patient has got mild hypertension or patient has got a lot of albuminuria. We know that edema is not a feature of preeclampsia, but I can swear for myself and I can swear for on behalf of all of you present here that if you get a patient with severe edema bilateral, I'm sure you're not going to ignore her. We need some kind of a thing to do for her. So there we have what we call as S-split1 or a soluble endoglin, PLGF or the placental growth factor, and a glycosylated fibronectin or glycine. Similarly, for prognostication, we have the S-split PLGF ratio and we have the glycine. Now, what are these? How do we do this? We'll go over in the next few minutes. So basically, now in our current practice, as I already told you, there are more than 100 biomarkers that are already there in the market. A lot more research is going on. But what we currently use could be mainly two types of markers, the proteomic marker, which is the glycosylated fibronectin, and the angiogenic marker, which is the PLGF or the placental growth factor, the PLGF S-split ratio, or the PAP-A. Now, I'll quickly finish the other ones, which are not very important for further prediction or for more severe kind of a prediction or prognostication. PAP-A is a glycoprotein produced by placenta. I thought there could be some postgraduates also in this crowd, so I have included a few sentences about what the biomarker is. Now, its maternal plasma concentration increases throughout the pregnancy. That means we need values at every stage of pregnancy to identify if I can use it. We all know that it is a part of use for screening of trisomy. We know that. So when I'm screening a patient for trisomy, and many of us have already taken up to screening for trisomy in a big way. So I have the PAP-A result with me. And if it is that, can I use it for preeclampsia? Now, decreased levels of PAP-A in the first trimester is associated with risk of PE. Now, as a single marker, if I say, okay, I'm going to do a screening for trisomy, I'm going to pick up PAP-A from there, and then I'm going to tell whether there is a risk for preeclampsia or not. Can I do it? No, because as a single marker, the performance is very poor. PIGO guidelines in 2019 said that PAP-A is useful if measurements of PLGF and uterine artery PI are not available. There are many towns where you may not be able to do a uterine artery Doppler, you may not be able to do PLGF, but I'm sure in the next few years, PLGF will be available everywhere without any doubt. So if it is not available, then you can use PAP-A as an alternative method. There are other markers, serum inhibin A, which we all know because we use it inhibin A for a lot of other things, including polycystic ovaries and so on. It is more sensitive than HCG. HCG we know is a marker for trisomy, but this is more sensitive for preeclampsia as compared to HCG, and they both identify the same underlying pathology. The next important biomarker, which is likely to gain more leverage in future, is what we call as the pentraxin 3. Now, PTX or pentraxin 3 is a tumor necrosis factor stimulated gene 14. It belongs to the family of CRP. So telling us that it tells us about the inflammation and tells us about the inflammatory pathogenesis of preeclampsia. Now, PTX3 plasma levels is increased in all the 3 trimesters in future PE mothers. That means whether I do it in first trimester, second trimester, third trimester, I would be able to use it. And then we have what is called as PP13 or the placental protein 13, and other marker which could play an important role in future. Currently, we are not using it. And now PP13 is produced only in the placenta. It regulates the vasoconstriction, vasodilatation balance, and also controls the metal artery remodeling. We all know metal artery remodeling is very important to prevent preeclampsia. It again also has an immune function role at the feto-maternal interface. That means when the dialogue goes on between the fetal cells and the maternal cells at the interface, PP13 plays a very important role, and low levels during the first trimester are associated with PE. That means if I do PP13, possibly I would be able to predict preeclampsia in a big way. And other important marker would be cystatin C, whose levels are increased in PE. Again, it is also a reliable marker for the first trimester. It is not clinically useful as a single marker, but we are moving into an era where you may be doing 5 or 6 biomarkers together, just as we started doing quadruple test and so on. Similarly, in future, we may be doing multiple biomarkers. That time, cystatin C may be used. And finally, we come to the all-important angiogenic markers. Now, we know that in the body, we have 2 kinds, the angiogenic factors and the anti-angiogenic factors. During pregnancy, we need more of angiogenic factors so that there is a lot of angiogenesis occurring in the placenta so that the fetal circulation is well maintained. Now, the angiogenic factors include PLGF, that is the placental growth factor, VEGF, very early growth factor, the PP13 and PAP-A, which we already discussed. The anti-angiogenic factors which prevent angiogenesis are mainly 2, the S-split and the soluble endoglin or SN. Now, naturally during pregnancy, the angiogenic factors take the upper hand as compared to anti-angiogenic factors. So there will be more of PLGF in a normal pregnancy. You see that is a heavyweight over there as compared to S-split, which is an anti-angiogenic factor. Now, if endothelial dysfunction occurs, then what happens is there is a decrease in PLGF and there is an increase in S-split1. Now, because of this kind of an increase, patient becomes prone for preeclampsia. So let's go a little more detail about these 2 factors. The PLGF or the placental growth factor is basically a dimeric glycosylated protein. I already told you that it is pro-angiogenic. That means it acts by non-branching angiogenesis in the placental vascular development. Now, this could be detected in the maternal circulation as early as 8 weeks of gestation, and it is maximal at the end of second trimester and declines thereafter until delivery. Now, what does this sentence tell us? Tells us that if I'm going to use PLGF as a biomarker, then the best time to use it would be first trimester and an early part of the second trimester. If I use PLGF only in the third trimester, then it would be a no-no. Now, reduction is significant in the first trimester, making PLGF an ideal marker for early screening. But then every good thing comes along with something bad. So the bad thing with PLGF is if I use PLGF as a single marker, then I can detect only 55% of early onset preeclampsia and 33% of late onset preeclampsia at 10% false positive rate. That means I cannot use this test as a single mode. I need to combine it with other factors, maybe history, maybe Doppler, and so on. The next important factor is S-split. S-split is an anti-angiogenic marker. So the full name of it would be soluble FMS like tyrosine kinase. Now, placental cells secrete this S-split, and various isoforms are secreted, and S-split 1 is very important. So it acts as an anti-angiogenic factor, that means prevents the proliferation of the blood vessels in the placenta and neutralizes both the PLGF and VEGF. Now, increased amount of S-split 1 are apparent in second trimester, but not in first trimester blood in women destined to develop preeclampsia. So again, the lesson we'll learn is that it cannot be used as a first trimester predictor. Now, once we knew that, okay, placental growth factor has to improve and the S-split 1 should be low, people started working on whether we could use an imbalance in the two biomarkers, S-split versus PLGF. And it was found that the imbalance in the two biomarkers could result in detection of PE more often. So the S-split to PLGF ratio is increased in pregnant women before the onset of clinical disease. Just imagine the amount of advantage that we have. I am suspecting that this woman could have preeclampsia. She has not yet developed preeclampsia. If I keep calling her every week for a check, she may not come, or a family will say, oh, this doctor is no good. He doesn't know what he's doing. Let's go to the next doctor. You know, these kind of things always happen in practice. So if I can find out that among all my suspicious preeclamptic patients, I can identify by doing S-split PLGF ratio that this particular candidate I need to really look in, I've ruled her in, then I'm going to be more careful about her. Now, the next question is, when do we use this test? The S-split PLGF ratio can be used from 20 weeks through 36 plus 6 weeks. You know, after 37 weeks, none of us are worried. Any doubt comes in of preeclampsia, we deliver, there is no issue about it. But we are definitely worried till late onset preterm, for late onset preterm babies. So it is a tool for short-term prediction and aid for diagnosis in women with clinical suspicion of PE. The ratio can also be used in women after 37 weeks, sorry, in all cases where preeclampsia is suspected, or as a follow-up on a patient to evaluate the uteroplacental dysfunction. That means I can keep repeating the ratio every 3 to 5 days, or maybe even every week, depending on the clinical symptomatology in the patient, and identify when much before the problem is going to come in. Now we know that we have basically a diagnostic cutoff of 85, whether it's for screening at 20 weeks or whether it is for prognostication. And it could identify a woman with preeclampsia with a sensitivity of up to 80%, 88%. That means if I say that this woman is not going to develop preeclampsia, 88% of the time she is not going to develop preeclampsia. But if I say, yes, this woman is going to develop preeclampsia, then I am right almost 99.5% of the time, which is an excellent figure. So basically, we use a ratio cutoff of 38. And this is the landmark paper from Zisler in 2016, which gives us the sensitivity specificity of this test. Now, what happens if the S-split PLGF ratio is high? Let us say it is not 38. It is not from not 38 to 85, but it is greater than 85, then we know that this patient is going to go in for a multi-organ dysfunction. So you get a very high figure in an split PLGF ratio, not just abnormal, but a very high figure. Look out, this patient can have multi-organ failure. And these are the various articles which have come over a period of time up to 2019 is what I've quoted here, which says the same thing, that split PLGF ratio is good for prediction as well as for prognostication. Now, how does the combination of factors and the biophysical markers also? Now, I'm basically talking about biochemical markers, but there are biophysical markers which Dr. Suchitra Pandit has worked a lot for getting the gestosis score. And we also have many other scores available to us. We'll be going into one or two a little later. And it has been found that if you use markers in combination with biophysical scores, your prediction may be even more better. And this is one of the calculators from the Fetal Medicine Foundation, where you could use, first determine the a priori risk, maternal characteristics of medical and obstetric history. You measure biomarkers, express them as MOMs, and modify the prior risk and estimate the posterior risk. This we all know, I'm sure you have all heard last time, that this calculator is available free of charge on the web page, and I think we should all start using this more and more. So when I do a combined multi-marker screening, I basically land up with a low risk or a high risk. If it is a low risk, I give routine antenatal care. If it is a high risk, I give her aspirin. If she is calcium deficient, remember we are in a third world country, calcium deficiency is known in our population. So I need to optimize the calcium intake, and I also need to do serial growth scans to identify FGR as soon as it comes in. Now, this first trimester screening, is it enough or can I do something more? I can do a first trimester screening followed by a third trimester risk assessment. When I do this, then I'll be able to pick up more number of patients. So this can be achieved in the first trimester. The first trimester achieving is mainly for early onset preeclampsia. Now, remember, by and large, majority of the consultants who are not working in a tertiary care center are likely to see an early onset preeclampsia not very often. What they are seeing oftener is the late onset preeclampsia. And I already pointed out that for identifying late onset preeclampsia, none of our tests are that good. So if we do a third trimester test, could I change the outcome for a late onset preeclampsia is the question that where a lot of work is going on. So two-stage strategy, first trimester and again in third trimester, could help us in identifying this. So first stage you do at 11 to 13 weeks for early onset PE. If it is positive, you can give low dose prophylaxis before up to 16 weeks of gestation. The second stage of biomarker testing you will do between 30 to 33 weeks for effective prediction of PE requiring delivery before 34 weeks and administration of anti-hypertensive and timely delivery. So this is the way that it could help us. I know I've been passing a few confusing messages. On one hand, I say biomarker is very good. On another hand, I say biomarker plus biophysical. And on third step, I say biomarker plus biophysical 2 times. Okay, all this would depend on the type of population you're looking at. You got a nice young primey. You just do a first trimester screen and you may not have to do anything. But we know now that we are seeing more of elderly patients, we are seeing more of diabetic patients, we are seeing more of essential hypertension patients, we are seeing more of IVF pregnancies. And when you have these kind of pregnancies, obviously your surveillance will have to be stepped up. So as far as prediction is concerned, the take-home message will be the biochemical markers are not effective when they're used alone. You need to use it with something else. Combination of other predictors such as risk factors or Doppler velocimetry will give you more effective model. Before better understanding of the pathophysiology of preeclampsia, hence better management, early identification and prophylactic therapy with aspirin. Now remember, preeclampsia may never be totally predictable. I have no hesitation in saying that. We will never be able to totally predict because preeclampsia is not one disease. Preeclampsia has got multiple etiologies. we will not be able to predict. It's not like typhoid where you say, I'll identify Salmonella typhi and say that this is typhoid. Preeclampsia is not like that. But better prediction would help us to focus on antenatal care more effectively. We'll be able to use our antenatal resources in a much better way. Now, with this, we go on to the next step of the talk, the prognostication. Now, again, there are questions here. Why we need to prognosticate? How do we prognosticate? And will it help in other placental pathologies like FGR? Now, why we need? If we can stratify the risk, again, we can modify the outcome. How? You use a multimodality approach along with biomarkers. Will it help in other placental pathologies like FGR? Definitely yes. Not only just FGR, it could help you in predicting accidental hemorrhage also. Now, risk stratification we know is a necessary prerequisite for risk reduction. So unless I stratify, I can't reduce the risk for my patient. And as far as as far as prognostication in later stage of pregnancy is concerned, we can use biomarkers for PE diagnosis, for short-term PE prediction, next 3 days, next 5 days, next 1 week, or prediction of adverse outcomes. Now, all our problems started with these two trials. The Hypertensive trial, which came in first, told us that induction of labor is associated with improved maternal outcome. So till the Hypertensive 2 came in, we all started inducing our patients with preeclampsia even as early as 34 weeks without doing anything further. Then the Hypertensive 2 trial came in, which was a study between 34 and 36 weeks of gestation. It was a randomized study, and it said the immediate delivery could improve the maternal outcome a wee bit, but there is a significant neonatal maternal morbidity and mortality. So wait on these cases for as long as you can, provided you do a strategy of risk modulation. Now, routine and immediate delivery is not indicated, and a strategy of expectant monitoring can be done in this patient. And for that, we need to really have a method to identify whom I can wait. Then came in the Phoenix trial and the FOGSI trial. The Phoenix trial told us that the maternal complications are significantly lower with planned delivery. Mind you, not early delivery. They are lower with planned delivery. And better maternal outcome at any stage of a delivery in preeclamptics as a trade-off of neonatal issues. I will be able to sacrifice a wee bit for the neonate, then I can save the mother. Then came in the FOGSI trial. What it said was, we had been taught by Chesley, the father of preeclampsia, that once you deliver, it's an end to preeclampsia. We now know that that is no longer true. Preeclampsia doesn't go away with delivery. Once preeclampsia comes, it marks that woman for life. So preeclampsia should not be considered as a self-limiting disease of pregnancy. Okay. After that, what followed was a full Pierce model, and you have a calculator like this available on the net where you could put in all the various characteristics. But this was done mainly in the 8 tertiary academic centers in the Western world, and it developed to validate an outcome prediction models based on maternal symptoms, signs, and laboratory variables. They took in all the 3 and came out with this full Pierce model. It accurately identifies incremental risk of maternal complications of preeclampsia. The AUC ROC, that is the area under the receiver operator curve that they found, was 0.88 to predict maternal outcome, adverse outcome in 48 hours. Now, 0.88, any of you are even a little bit in know of statistics know that 0.88 is a fantastic figure to have it under AUC ROC. Now, this was validated both in internal as well as external models. Now, again, we come to the third world countries. We know we cannot do all the lab tests in all our patients as a routine who are not yet preeclamptic. And so therein came in what we call as the mini Pierce model. The mini Pierce was a simplified version of this model used in community and the PHC facilities, and it was based solely on patient demographic signs and symptoms. No laboratory investigation was done. So you could sit, talk with the patient, identify the patient, and use it to get some kind of prognostication. After that, more and more trials came in. Next came in the Peacock. The Peacock again said that if you the prognosticated indicators, including PLGF, was used in the first Peacock study, and then came in the Parrot 1 and Parrot 2, where again PLGF was used to assess the women with suspected preeclampsia. They were all multicentric randomized trials. Then came in the Parrot 2, which told us whether if I repeat PLGF, not just do once, if I repeat PLGF, would it be of use? And Parrot 2 found that yes, if you repeat, it is of use. After that came in the Parrot Ireland. And we know Irish are very conservative as compared to English. And what Parrot Ireland said is that no, it's of no use. Don't do PLGF, it doesn't work. Okay. And after that came in again what we call as the Pelican study, all named after wonderful, beautiful birds. The Pelican study, which said that the placental growth factor could diagnose preeclampsia requiring delivery within 14 days if you use a PLGF as a marker. Again, a little confusing, but we'll come to a conclusion at the end of it. So to measure PLGF, what we have is what we call as a PLGF triage meter test. This is a bedside test. If your hospital is doing, let us say ABG for quite a few of your patients, then you're using the machine of that particular company, you can use the strips and do a PLGF for quite some time. And the recommended triad would be a PLGF less than 12 picograms per ml. It's test positive, highly abnormal, and suggestive that the patient could develop problems and can definitely have preterm delivery. Okay. Now, I had given this topic to one of my postgraduates as a dissertation topic about, I think, 3 years back. And what we found in our study was exactly what was being told so far. You can see here that the PLGF values are totally different as compared to normal PLGF values. If a patient is going to be normal, the PLGF values are going to be different than if the patient is going to develop a severe PE. There is no overlap in the values. That means that tells us that this test could identify problems very well. And this is what we did. My study was not very big. I think it was 100 preeclamptic patients. And we found that whenever PLGF was less than 12, the chance of patient having a problem was very high. The only thing which we couldn't identify was accidental hemorrhage occurring in a few patients who showed a PLGF normal but still had accidental hemorrhage. Now, next we go to the wonderful prognosis study, which came out with a predictive value of S-split PLGF ratio in a woman with suspected preeclampsia. And this study was finally, again, the findings were confirmed by the INSPIRE study. So prognosis and the INSPIRE, these two studies form the foundation stone of using the S-split PLGF ratio in our clinical practice. Now, prognosis was a prospective, observational, multicentral study where the SFLT PLGF ratio of less than 38 could rule out preeclampsia within 4 weeks of a negative predictive value of 94%. I think it's an excellent figure because if I know that my patient is not going to be developing preeclampsia at least for 4 weeks, then I don't have to call her every alternate day or every week. I can call her at the end of 2 or 3 weeks and repeat my ratio at the end of 4 weeks. Okay. Now, INSPIRE confirmed the result of prognosis and strengthened the case for the S-split PLGF ratio as a rule-out test. Remember, this is not a rule-in test where I can say, now this patient is definitely going to have a problem. It's a rule-out test. I can tell my patient, you're going to be normal for the next 4 weeks. That's the meaning of rule-out. And S-split PLGF ratio incorporated into the clinical practice recommendation and guidelines. Germany was the first country to include S-split PLGF ratio in their guidelines. And now many more countries are coming up to include. US is standing a little apart because they're still not including the biomarkers in a big way in their guidelines. But the International Society for Hypertension is now starting to include biomarker. And very soon we may have a guideline which includes biomarkers. Now, I'm very proud of this particular study called as Robust study, which was published in 2021 for the simple reason that this study was done by one of my fellows. And you know, when your Shishya does things, the guru feels much more happier. So this is one of my students' study, which was, this Robust study was published in the prestigious journal Hypertension. And there also the same thing was found that if the ratio is greater than 85, we don't have to worry. The outer circle is greater than 85, and it is greater than 85, you don't have to worry. Now, we have got two figures. I'm sure you have already heard me talking 85 and 110. So that could result in the confusion in the mind. Is 85 normal or is 110 normal? Lower down, 38 is definitely normal. If you read a few articles, it could tell you 33. But now we know that between 33 and 38, there is not much difference. So now we have taken 38 as the lowest value. And the upper value is 85 for an early onset preeclampsia and 110 for late onset preeclampsia. So that's how it helps me to identify and separate my patients into different groups. Now, if the SFLT-PLGF ratio is more than 85 or more than 110 for late onset, if I'm considering, then the diagnosis of PE or placental-related disorder is highly unlikely. It presents information before the onset of signs and symptoms. Very high ratios. If I'm not getting 110, but I'm getting 150, 160, 180, then I need to deliver this patient definitely in 48 hours. Trending, that is remeasure after 2 to 4 days and then manage. So trending is very important for me to identify, especially in a subset of population which is at higher risk for preeclampsia among my group. And test frequency is adapted to the clinical situation and the ratio that you have found. So you have to alter it as per your clinical situation. There is nothing that is you will do every 3 days or you will do every week. Now it helps us in the clinical decision making, as I already told you, that the value of 38, 85 to 110, greater than 110, or much more greater than 110, how it progresses. The next important biomarker is called as glycosylated fibronectin. And now why glycosylated fibronectin is important is because it's a point of care test. You can do this test at bedside. It's just as you do your urine albumin with the strip, or you do your urine pregnancy test with the strip, the glycosylated fibronectin is exactly the same way you could do. It is cheaper and it gives you immediate result. You know, our preeclamptic patients tend to come on Friday night or Saturday night. And if you try to send any test to the lab, you may not get it till Monday. So you need something that tells me now, what do I do? And glycosylated fibronectin is one such test. You can do a finger stick sample. It is a quick 10-minute test. Rule in and rule out are very common. You can do a triaging and ambiguity and repeat the test, and adverse outcomes are very easily identified. Now, you can see this particular chart that glyphine tests are elevated in clinical preeclampsia. Now, this green line is a patient who never developed preeclampsia, whereas the red line is a patient with developed preeclampsia somewhere along over here. And we found that the area under the receiver operator curve is almost as high as 0.94. That means it is at least as good as SFLT-PLGF ratio. But it is a bedside test. It is a cheaper test which you could do. Now, interpretation, it is less than 250. The meter tells you, you don't have to do any calculation, nothing. If the value is less than 250, then there is a negligible risk of preeclampsia and the test result is valid for 4 weeks. If it is between 251 to 350, there is mild or developing preeclampsia, repeat test after 2 weeks. But if it is 351 to 600, then there is a high risk of preeclampsia. And if it is highly positive, that is greater than 600, then there is a presence of severe preeclampsia with high risk of imminent delivery. Now, I'll just point this out a little bit when I quickly take you through a test. Now, glycosylated fibronectin, that means we are talking about fibronectin which has been glycosylated, or a glucose molecule has been impregnated over it. Obviously, the doubt comes into the mind, if my patient is gestational diabetes mellitus, where the glucose levels are high, will it alter my glyphine ratio or not? So it has been found that in GDM, if you ask till 350 micrograms, you could take it as normal. But if I get a value of about 351 to 600 or more than 600, GDM or not, it is definitely important. So that way we don't have to really worry about the glycosylation of fibronectin, not because of preeclampsia, but because of diabetes. There are many clinical studies and validation that has occurred for this particular biomarker also. And as I already pointed out, the ROC curves are very good for this biomarker. And we also did a study of, again, about 100 patients last year on glycosylated fibronectin, and we found that look at this, when there is this is negative, this is positive. In the control, that is in suspected preeclamptic, the positive values were much higher. I mean, the negative values were there, they did not develop preeclampsia. The positive values developed preeclampsia. And this is the kind of complications that developed in each of this, again proving that glycosylated fibronectin can be used for prognostication. So with this quickly, I hope I get another 5 minutes. Madam, is it okay if I take 5 minutes?
Sir, as early as possible, because we...
So case 1 would be Rulin, where a 28-year-old primary gravid at 37 weeks of gestation comes in. She has no history of any severe preeclampsia, but she's 35 weeks and 2 days. It shows a mild IUGR. Umbilical artery shows decreased diastolic flow, no brain sparing changes. But her blood pressure was 130 by 90. Repeat blood pressure was 120 by 80. Her investigations are normal except for raised serum uric acid. Give me a small doubt in the mind, am I dealing with preeclampsia or not? So what do I do in such a case? So we did the glycosylated fibronectin, and to my surprise, it came more than 600. And look at the type of non-stress test when I did. It's not a very good trace. It's a suspicious trace, very small acceleration, variability not too good. And after discussion and counseling, I admitted the patient. Now, I admitted her in the morning. In the middle of the night, the patient started to develop hematuria. BP became 180 by 100. Started her on magnesium sulfate. Patient's condition was discussed again with the couple, and I had to do an emergency LSAs at 2 a.m. in the night. Brought out a 2.54 kg female baby, and look at the amount of hematuria that this patient was having. Okay, there was accidental hemorrhage. You can see in this picture that there is accidental hemorrhage, intraoperative bleeding, and generalized oozing occurred. I got away with the medical management of PPH, and finally the patient could go home. And in this particular picture, apart from the couple, I've also shown the mother-in-law, because we know in India, mother-in-laws are the biggest obstacles to admission and delivery. But this particular mother-in-law was good, and I could save both the mother and the baby. So I included her in the picture. Now, one example of rule out, this was a patient who was 30-year-old primary gravida with 30 plus 6 weeks of gestation. Her BP was normal, but she had abnormal liver enzymes and thrombocytopenia with raised serum uric acid. I'm sure a very confusing picture. Am I dealing with preeclampsia, or what am I dealing with? With raised liver enzymes and thrombocytopenia, 30 plus 6 weeks, maximum I would get is 2 or 3 days. But if it is not due to preeclampsia, I can continue our pregnancy. So the question came in, what to do? We did the glycosylated fibronectin test. It was only 250. So I continued our pregnancy. 4 weeks later, it was 351 to 600. And it was 351 to 600. And that was 4 weeks. She was now by 35, almost 35 weeks. So I decided to deliver her. And we delivered a nice male baby at 35 weeks, which did not require NICU care. Now, this patient had her elevated liver enzymes and her thrombocytopenia due to autoimmune hepatitis, which we could diagnose much later because we do the other markers for autoimmune hepatitis. But it did help us to continue the pregnancy because the biomarker was normal. So now basically using a biomarker, you can have this kind of a protocol. And when you have a management based on biomarker, the management reduces unnecessary admissions, reduces iatrogenic preterm deliveries, optimizes maternal condition and monitoring, optimizes fetal condition, and plan for anesthesia and labor are much better. So to conclude, many obstetricians are still skeptical about the use of biomarkers for the evaluation of preeclampsia. But remember, when you focus on problems, you get more problems. When you focus on possibilities, you have more opportunities. Thank you all very much for a patient hearing.
Dr. Pratima.
Madam's connection got lost.
Dr. Mehta, it was awesome. Awesome. Awesome is a small word.
Thank you, ma'am. Getting praise from you, I feel I'm blessed.
People like me have to read this particular thing again. You know, I'll ask Dr. Achla to give me a favor, to give me a recording of this. It was awesome.
It will come on the
recorded. It is recorded.
It was awesome.
Thank you.
Achla ma'am, can you please conclude the session? I think Dr. Pratima has some issues in the connection.
I would just echo Dr. Sharda Jain's words that it was awesome and everything was so clearly defined. I always tried to read this topic, but somehow in between I would leave it, because get a little confused. But Dr. Mehta has very clearly and very crisply told us, the values, when to do, how to do, and especially the two cases, they really explained it all. So thank you, Dr. Mehta. You were going beyond time, but none of us wanted to say anything because we were so engrossed in it. So I think the panelists will excuse us, but we didn't want to, interrupt you because it was so good. Thank you very much.
Thank you.
Monica?
So with that wonderful session, we now move on to another interesting session of a panel, which is a case-based discussion on preeclampsia. And to moderate the panel, we have two very important teachers from our institute, Safdarjung Hospital, Dr. Jyotsna Suri, who is also the Vice President of AOGD, and she's professor in Department of Obs and Gynae in Safdarjung Hospital. She's the in charge of critical care obstetrics in Safdarjung Hospital. So no
Monica,
better
let's
person.
go ahead. We are already late.
Okay, ma'am. And her co-moderator is Dr. Garima Kapoor, who's also professor in our hospital. And the expert for this session would be Dr. Suchitra Pandit, whom we have already heard. And she will be giving her, she's been instrumental in Gestosis India, so she'll be giving her expert comments for this panel. The panelists for the panel are Dr. Anjali Dabral, who's the head of the Department of Obstetrics Department in Safdarjung Hospital, and with special interest in high-risk pregnancy. Next, we have Dr. Girja Bagh, who's professor Obs and Gynae in Bharati Vidyapeeth Medical College, Pune. She is a senior consultant in Cloud9 Hospital and also faculty professor in OGASH International Experts General Coordinator. She has been Vice President of India Chapter Gestosis since 2014. So she's an important panelist amongst us for this panel. Next, we have Dr. Devendra Kumar. He's professor in obstetrics and gynecology in Maulana Azad Medical College and with special interest in antenatal care, endoscopy, and medical education. Next, we have Dr. Rinku Sen Gupta, who's a private practitioner and senior consultant in Sitaram Bhartiya Institute, New Delhi. And her special interests are in reducing interventions in low-risk obstetric care, point of care quality improvement initiatives, and minimal access surgery. Welcome, ma'am. Next, we have Dr. Leena Sridhar. She has been the senior consultant at the Manipal Hospital and ex-HOD of the Department of Obs and Gynae. And currently, she is the head of academic and research wing of the hospital. She's also the secretary DGF Dwarka and an executive member of the multidisciplinary committee AOGD. Welcome, ma'am. Next, we have Dr. Shruti Bhaskaran, who's associate professor in obstetrics and gynecology in GTB Hospital. She has been co-editor of NARCHI and AOGD and also the executive member of AOGD Rural Committee. So I welcome all the panelists, our two moderators, and Dr. Pandit, our expert once again. So over to you, Dr. Jyotsna, for conducting the panel.
Yeah, warm welcome to all our panelists and also to the delegates. And after the wonderful, crystal clear and such a it was really stimulating lecture by Dr. Prakash Mehta, we can go and actually now discuss two cases which we managed in our hospital in the last month. Actually, both these cases were admitted in February. So Dr. Garima will be doing the first case and I'll join in the second case. Garima, you can start the first case.
Thank you, ma'am. And without wasting any further time, I would like to just go on to the topic of today. Preeclampsia in India, the incidence is around 10.3%, and the incidence of eclampsia as reported is almost 2%. and nearly 50% of these cases are antepartum. Talking about maternal deaths, the 2014 data suggests that 19% of the maternal deaths were due to hypertensive disorder. Our own hospital data, this is before the COVID era, showed that almost 28.2% of the maternal deaths were due to hypertensive disorders of pregnancy, and per se for eclampsia, 4 to 6%. So this is a huge amount of morbidity and mortality when we are talking about this syndrome. And this is our data from the critical care unit at our hospital, which shows that nearly 30% of the CCU admissions are related to hypertensive disorders, this preeclampsia, eclampsia syndrome. So with this knowledge, we all know that the hypertensive disorders are classified into gestational hypertensive, preeclampsia, chronic, and eclampsia. We all are aware of that. These are the standard definitions, and we all understand that preeclampsia now is a syndrome where it is not just defined by proteinuria but by end organ dysfunction also, which may exist without proteinuria, as Dr. Mehta had previously told us that it's not a single disease entity. This is actually maybe a syndrome with a lot of different disease entities. And these definitions are very standard, and I think we all are aware of these standard definitions. So now coming on to my case one, this is a 33-year-old lady. She came to us as Gravida 2 Para 1 Live 1 at 32 weeks, 2 days period of gestation with previous one cesarean, who had visited to us in the antenatal OPD for a routine examination. Her blood pressure was found to be elevated at 175 by 110 millimeters mercury with urine albumin 2 plus. This was when she just walked into our OPD. So my first question goes to Dr. Anjali. Madam, what is the provisional diagnosis and what is the correct method to measure the blood pressure?
Good evening, and thank you organizers for including me in this panel. Since her blood pressure is 170, 110, the patient fits into the criteria of preeclampsia with severe features. And the second question is how we should take the blood pressure. The patient should ideally be seated if she can. Otherwise, if she's lying down, it should be in the left lateral position. Her feet should be supported, and she should rest for at least 3 to 5 minutes before we take the blood pressure and not talk to anyone during that time. And the gold standard is the mercury sphygmomanometer, in which we hear the Korokov sounds 1 and 5 and 1. And otherwise, we are nowadays using a standardized digital apparatus to take the blood pressure. So that's the way we take it. And the blood pressure should be ideally measured using a standard cuff, unless her arm circumference is more than 33 centimeter, in which case we will use a large cuff. And the cuff should be 2.5 centimeter above the antecubital fossa. And ideally, both arms should be measured and a mean taken. And after that, we can use the right arm.
Thank you, ma'am. These were the FOGSI guidelines that have been laid down for the measurement of blood pressure. Very simple, but to make it very precise and accurate. Now, this patient had no complaints of headache, blurring of vision, or epigastric pain, or shortness of breath. Essentially, she was asymptomatic. When we examined her again, she was her repeat blood pressure was 169 by 102 millimeters mercury, pulse 88, respiratory rate 16, and for abdominal examination, she corresponded to 30 weeks pregnancy, cephalic, and a transverse scar was present, and there was no scar tenderness. Essentially, it was a relaxed uterus. So my next question is for Dr. Devendra sir. What is the initial assessment and care you would provide to this patient? And what hypertensive would you like to give, which and when?
Thank you for that opportunity. Actually, these patients, no doubt, should needs inpatient management. This patient should be immediately admitted into the hospital, and all the basic investigation and their this thing should be tabulated. When I'm talking about it, that means all things has to be in a normal, even her blood group and basic hemoglobin, platelet counts, peripheral smear. But specifically what we target in these patients, certain investigation we group under maternal as well as fetal. In the maternal, what we talk about to rule out HELP syndrome and her abnormal elevated liver enzymes It should not happen that it's because of some other viral infection or some other problem. That also has to be taken care. In the fetus, we have to learn about umbilical artery Dopplers, and if any abnormality is found there, then simultaneously we have to do the assessment for the middle cerebral artery as well as ductus venosus. Now here you have already said that the period of gestation was 32 plus 2, and the symphysis of fundal height estimation was 30 weeks. So that means the growth is already lagging by 2 weeks, and it may increase further. So definitely we must chart their growth, fetal growth, for a further this thing. Whenever these type of patients are admitted with such a high blood pressure, and our targeted standard management is this, that whenever baby is systole is more than 160 or 110 diastole, then we give them injectable labetalol. Initial dose what we are using, this is a first line management for us, and initial dose what we are using is at 20 milligram, and then we wait and repeat, and then further we titrate 40 and another 80. Maximum dose is up to 300 milligram at a 20 minutes interval. And what we try to maintain, that BP systole should be between 130 to 140, and diastole should not be more than 100, or it should be less than 100. With keeping these things, antihypertensive and investigations, we have to also simultaneously plan further management with these such high BP as well as urine albumin. We have to ensure that conversion should not occur in these patients. So for a preventive measures, we at Maulana Azad Medical College, we initiate them on prophylactic MAGSELF, and depending on the fetal growth parameters and fetal heart rate or NST, we further plan her. We consider delivery in case BP is not controlled despite our full doses of antihypertensive, and if there is there are premonitory symptoms like headache or blurring of vision or any other thing like that. And there are few more things which we have to consider. Whenever these patients come, they may have associated anemia or other complications, which has also to be taken care during management in patients.
Thank you, sir. Here, I would just like to highlight now that after the CHIPS trial, the guidelines are now moving towards a more stricter control of blood pressure. And now they even say that at 140/90, we should commence treatment of hypertension as per latest NICE guidelines 2019. And they say that by control of hypertension, many morbidities because of high blood pressure can be prevented, though it does not affect the final mortality, without having any adverse neonatal outcome. So this was basically after the CHIPS trial that has come, and sometimes patients do come like this one also. She had high blood pressure, she was diagnosed, and she responded beautifully to our oral drugs. This is the range of drugs we all are aware of: labetalol, nifedipine, and methyl-dopa, which is now no longer available, freely available. So we all know that labetalol is the first drug of choice, and the dosing we all understand the tablet, and the other options are nifedipine. Methyl-dopa is obviously right now not available, and these are some of the drugs to be avoided. So this patient was admitted in the ward.
Can I just add here?
Yes, sir.
Somebody
Yes, sir.
in that chat, they have asked for 32 weeks with no symptoms. Should MAGSELF be started? Now here what happens is this: if the patient is having persistently high blood pressure despite all your full doses of antihypertensive, and if the symptoms are not there, we have to take care that we have to consider delivery. We have to plan the delivery, because as initially it was considered that once the patient delivers, the symptoms are controlled. The problem what here means we have to understand is this: persistent high BP may predispose to cerebrovascular accidents, which are more severe or dangerous, or mortality is more common in those cases.
Garima, can I just interrupt you?
Yes, ma'am.
Yeah. See, the other advantage at this 32 weeks is it is also giving the neuroprotection, particularly between 28 to 32 weeks. So if you're giving the MAGSELF, there are dual advantage to the patient as well as to the baby.
I agree.
There's a different.
Yes, I agree, ma'am. But I think what the delegates probably want to know is that with this blood pressure, do we need to give MAGSELF if we may or may not terminate? So we are in a fix many times. So what we do at our institute is we initially, if you're not comfortable with the blood pressure or a picture, we do put her on MAGSELF, but then we review our decision. If she responds to treatment, then we may reconsider it also. And it doesn't necessarily mean that you have to terminate the pregnancy. We can always review and reconsider a decision after the reports or with further blood pressure management. Like for this patient, she was admitted, we put her on Maxil dose because we're uncomfortable about the blood pressure to begin with. And but her BP responded beautifully to labetalol, and she was not at all symptomatic. We did start her on injection dexamethasone. So then we ordered for her investigations. So these were some of her investigation from the preeclampsia panel. And as you can see, madam, that her LFTs have been slightly deranged. The SGO, AST, ALT were 252, 216 and zero point 0.9, and LDH was 548. And repeat profile was 398 and 410, and there was a slightly deranged. So this was the initial picture that we got. So my next question goes to Dr. Rinku Sen Gupta. Madam, could you please tell her that what in this condition would you like to do? Would you, if you've started her on Maxel, but her blood pressure is controlled, she's essentially asymptomatic with a just slight deranged LFT, would you go for an expectant management or would you want an immediate delivery for this patient?
So thank you, Dr. Garima. One thing that I would also like to know is, preferably if we could have our ultrasound findings of the baby. Initially, I mean, what I understand is the baby is okay, and if the doctor flows
I
everything.
can give you, ma'am, this finding. We had done a scan on this. She had FGR, and her umbilical artery PI was raised. There was absent end diastolic flow in 1/3 of the loops. All the loops, it was not. We had a decent flow. It's only in 1/3 of the loops there was absent end diastolic flow.
Okay, so there is a compromise, definitely.
Yeah, definitely.
Now, the thing is that what I feel is that I don't know whether I can label her straight away as severe preeclampsia, because her first BP was high and the second one just came down on its own without your giving any antihypertensive.
No, it came down with antihypertensive.
Acha, okay, so that is something I must have missed. So,
Yes,
okay, anyway, now the point is that when I look at her lab reports on the first day, the second day, I think, the day after
at admission, those were the at admission.
Okay, at admission, they of course the liver enzymes really make me a little uncomfortable. The serum creatinine is also a bit on the higher side considering pregnancy. But at 32 weeks, 2 days, I would wait till her antenatal steroids are over. But once her antenatal steroids are over, that means after 48 hours for this particular patient at 32 weeks, 2 days, and with a compromised fetus, I wouldn't like to wait anymore. I mean, this lecture of Dr. Prakash was absolutely mesmerizing, and I feel that some of the predictors, the biomarkers that we are talking about, they are probably not applicable in this case, because this is a clear-cut case, where there is no doubt if with a compromised baby and with this high blood pressure readings and albuminuria and these lab findings and the kidney functions deteriorating further, we need to definitely terminate the pregnancy. But I suppose in some situations where we are in doubt, or we are not very clear, the blood pressures are mostly normal, then maybe we could consider a biomarker screening like we talked about. Of course, personally, I have no experience about the FLIT, the FILT at the PLGF ratio. I believe it is expensive. But what I understand is that the RCOG talks about the PrEP-S model, where, we could feed in all these parameters and then we could see whether this mother is going to have not a very good prognosis in the next 2-3 days. But I think this case that you discussed, Dr. Garima, is quite straightforward. I mean, we need to deliver her. That would be my opinion.
Yeah, so I think I'll just thank you, madam. I think I'll just summarize what you have said. That on one hand, we are worried about the fetal prognosis, the perinatal morbidity and mortality. On the other hand, we are worried about the maternal complications. So there have been studies in the literature which have shown that with early onset, you have very high perinatal mortality is there. And what is exactly the role of conservative? So this is the systematic review which was done on 39 studies that showed that with expectant management, we were able to prolong the pregnancies by 7 days without any increase in the maternal complication. So that is a major concern. So in selective cases, that is very important. And this is an algorithm that we have. It's looking very busy. I'll just simplify it for you. See, the choices are very clear. In a pre-viable pregnancy, where we know that we cannot prolong it much earlier, depending on your setting, your nursery, you will terminate the pregnancy. For a patient beyond 34 weeks, the choices are clear that we will terminate the pregnancy because planned deliveries is better than your expectant and management. The problem is between the viable gestation and 33 plus 6 weeks, as has been in this case. So there they have divided into two categories. They have 2 or 3 categories. Basically, they say that is it preeclampsia with severe fetus only based on blood pressure criteria. That essentially her biochemistry is normal and she has only high blood pressure. There is no other compromise, or there is only biochemistry that is altered. Otherwise, your blood pressure has been managed and she is controlled, and there is no other compromise. So if you have only the blood pressure or only the lab features which are abnormal and which are settling down within 24 to 48 hours, they are not deteriorating further, and you are comfortable with it, in those selected cases where there is no other indication for termination like end organ damage, IUD, abruptio, any other like HELP syndrome, where you have no other this kind of a complication, you may consider expectant management. Because the biomarkers are still not freely available with all of us. So
just one important point which I'd like to put here.
Yes.
Your LDH levels are also on the higher side. So I would be very worried when there's a early rise in LDH. The early HELP syndrome, it is built.
Yeah. I was coming to that, right? A partial HELP kind of a picture is there.
Yes.
I mean, a partial HELP. Yes.
I completely agree. In fact, for this patient, as you can see, we had started her on dexamethasone and Maxel, which was dual protection for neuroprotection also. And we waited for that, and we found, because her blood pressure was absolutely normal, she was asymptomatic except for a deranged LFT. But within the next 24 to 48 hours, what we found that her LFTs are not improving and her KFT is also deteriorating, and her LDH also came out to be positive. So we took a call for termination with the knowledge that there's absent end-diastolic flow in 1/3 and the baby is affected. But we waited for DEXA cover and then we took the decision for termination. The take-home message is that we need not panic at one report. If your otherwise patient is well preserved, in selected cases you can wait for 24 to 40 hours and see how she progresses and then take the call. And the progression, again, as sir has already discussed, I think he's discussed in details in the full PIAS model. So I think we can skip this part. So my next question goes to Dr. Girija ma'am. What are the predictors for preeclampsia and early pregnancy, and what is the role of HTP dystosis score? Madam.
I think thank you, Garima, and I was just going through all the discussion, such a wonderful, collection of slides you've got and wonderful evidences. And it's really, really nice. And I'm sure that all of us are going to benefit extensively with this. Yes, now one of the most important things is that when we talk of biomarkers, we essentially, that doesn't mean laboratory tests. Biomarkers also can be her, situations. There can be clinical issues that she has. Even these can be named as biomarkers. And these would help us in categorizing this patient or risk marking this patient so that we can effectively then use surveillance. Because looking at the population and the amount of antenatal care, that quantum that keeps on coming to us, we should be able to segregate, okay, these are the ones which may probably get into. For example, when we are talking of the previous patient, Garima, I just wanted to point out that quite a few patients are having deranged liver function tests as they go towards term. And many of them have this setting of AFLP, and that can cause confusion. Likewise, LDH segregation would be mandatory, because sometimes after you given magnesium sulfate and steroids, their LDH reverts back to normal, and then we can have that window of opportunity. So we have to, therefore, nothing can be said XYZ, and that is the challenge probably in preeclampsia, that we have to understand that it is a transitory phase and you have to put these patients under surveillance. But then putting all of them under surveillance will make a normal thing like a pregnancy unnecessarily a pathological condition, and therefore we can use these clinical factors. Now, what is so important about these clinical factors? These are the ones which you have put up here on the screen, are the ones which the NICE has been talking about, the high, moderate, and the low risk factors. And these have been based on the evidences that we have seen that, for example, autoimmune disease, chronic renal diseases, these are the women who are going to have such kind of occurrences. Likewise, whenever a patient comes to you with a previous obstetric event, it's important to find out, was it a preterm delivery? Was it a patient who had a fatal growth restriction? Because even that can give you a clue. And this helps us in better application of our antenatal care surveillance at the outset when the patient comes to you first. What is the challenge, however, in this, and why the question that you asked, the second part of your question was Justosis score. Now, why Justosis score? Because if you look at these factors, I want you to go back to the same slide if you want. Yeah.
Okay, I can go back to the same, ma'am.
The same, nice, yeah.
I'll get the Justosis score, ma'am. Okay.
Yeah. So the NICE guidelines, if you see, there are few things which are not mentioned there. One of them is the age, which is low, because we have women who are lower than 20 years of age who have a very high incidence of preeclampsia. Secondly, the interval from the time that they initiated sexual act and they became pregnant. If there is a low interval of sperm exposure, and whatever I'm saying, these all have evidences. For example, bipolar disorder, schizophrenia. These women have nearly 3 to 4 times possibility of developing preeclampsia. So all these other factors, so whenever we are looking at the SPRE study, all the other studies, and the NICE recommendations, the ACOG recommendations, they are not mentioning all these risk factors in detail, because this may be specific for their Caucasian population. In the Asian population, the Justosis score not only involves hypothyroidism, PCOD, maternal weight gain, and emerging factors like GDM, because we do not have so much easy access to the biomarkers like the S-FLATE, PLGF1, even the uterine artery pulsatility index will not be very easily available. Patient may not turn up at 12 weeks. So even if she comes whenever, we can just put her through the screening, and that can help us in identifying. And what we felt is that scoring of 3 or more would be the one which will segregate them as low risk mothers and high risk mothers. However, this requires validation, because there are now at this point in time 2 publications done on Justosis score, and they have found that this score 3 feels good. But now, right now at my end, I'm trying to analyze the studies, the patients that have presented to us. And in a retrospective analysis, I'm still thinking whether we have to keep a range or whether we should use 3 as a cutoff. So I think I've been able to answer your question satisfactorily. What is very important is ACOG guideline in their risk factors have included ART pregnancies, and Justosis score differentiates. Not all ART pregnancies score 1, but if it's an ICSI pregnancy, if it's an oocyte donation, then it will be scored a little higher score. So this will improve our sensitivity and sensibility towards this patient, so that we can use prophylactic mechanisms like low dose aspirin, putting them under closer surveillance, ensuring that they take good diet, nutrition, which is high in folates, proteins, and also ensure that they are taking calcium supplementations. Yeah. So that is the purpose.
Thank you so much. So for comprehensively explaining to us the Justosis score, I think we should be all proud of this. This is our own indigenous score. And there's just one mention, sir has beautifully mentioned about this, so there's no point discussing it. The only thing I would like to add here is that there's ophthalmic artery Doppler also. There have been studies in systematic review which have shown that high resistance in these vessels it's a very simple bedside thing you can do and predict early onset preeclampsia. So maybe this also could be one of the future ways in which we might be using it. This is just purely based on the hypertension and not the preeclampsia theory. And obviously, aspirin we need to start and continue till 36 weeks pregnancy or preeclampsia or labor, whatever occurs earlier. My next question is for Dr. Leena Sridhar. Madam, what is the risk of recurrence in next pregnancy, and what are the long-term sequelae of this preeclampsia, this hypertensive disorder?
Yeah, thank you very much for having me on the panel. Just like Dr. Mehta mentioned, that preeclampsia should really not be considered a self-limiting disease of pregnancy. And what happens is once the patient has delivered and gone home, for many times she's lost to follow-up. She has to be made to understand that it is very important, especially in the first 3 months, post-delivery, that she has to be under surveillance. It would be a good idea to inform her that even if her blood pressure is touched to normal post-delivery, she must check her blood pressure and initially report it about 2 to 3 days after she has been discharged from the hospital. Why so? Because she is to be told that there are some very long-term consequences of women with preeclampsia, and there has been seen that there is a higher risk of both cardiovascular, neurovascular, renal, metabolic, and central nervous system disorders. There's a very high risk of chronic hypertension, ischemic heart diseases, coronary artery diseases, cardiomyopathy, thromboembolism. a lot of women have reported, cognitive dysfunction, memory loss as a long-term problem. There's a higher incidence of stroke, retinal detachment, diabetic retinopathy, also the metabolic syndrome, dyslipidemia, obesity, and type 2 diabetes, apart from having renal consequences in the long term, both glomerular dysfunction and renal failure in the long term. For consequences for the baby, both perinatal and neonatal complications that are associated. For short term, we all know that there is a very high incidence of preterm births, fetal growth restrictions, even intrauterine fetal death, oligohydramnios, a very low Apgar score, and like in that case that was mentioned, a non-reassuring NST, non-reassuring fetal heart rate in labor. The long-term complications for the neonate, cerebral palsy, there is babies born with a low IQ, with hearing losses. In the long term, as the babies grow up, there is a higher incidence of diabetes, developing hypertension and coronary artery disease as they grow older. So what is important for them to understand is that like I said, that it is not a self-limiting disease, and many of them want to know that, okay, what is my chances of developing preeclampsia in the next pregnancy. So it is very important that when they plan the next pregnancy, they come for a preconception counseling. It has been seen that there is a higher incidence as high as about 16% in women for having a recurrent preeclampsia, or even hypertension in a subsequent pregnancy. And what has been seen is that if in that index pregnancy they had a very early onset preeclampsia, that is less than 34 weeks, then they have a much higher incidence, or as high as 25 to 65%. But if they had milder features and in their very first pregnancy, then it falls down to about 5 to 7%. As you compare it with a woman who has been completely normotensive throughout her first pregnancy, then her risk of having it is as low as 1%. So basically we have to counsel them when they are planning their next pregnancy. And it has also been seen that the risk is also there for the babies in a future pregnancy. There is a higher risk of both placental abruption, growth restriction, preterm deliveries, and overall a higher perinatal mortality. So this has to be made very clear to them that there is a long-term sequelae and that they should come for counseling when they plan their next pregnancy.
Thank you, ma'am. You have beautifully summarized the long-term effects on the fetus and future pregnancies. And going on to my next question, this is for Dr. Shruti. What contraceptive advice will you give to this patient post-delivery?
Thank you, Dr. Garima, for including me in the panel and for the question. So, it will depend on the couple's preference, the type of contraceptive that they choose. But because most probably this patient will be going for cesarean section, she might want a permanent method of sterilization because this will be her second child or ligation. So in that case, we have to counsel her for delaying the procedure, because Government of India guidelines clearly say that ligation should not be done in a case, it should be delayed in a case of severe preeclampsia. So other methods should be advised to her, and effective methods will include a long-acting reversible contraceptive method. For her, during cesarean section, a PP-IUCD can be inserted. That will be the ideal method for her. But if she refuses, then other methods can be offered to her, like in the form of injection DMPA. One important point regarding injection DMPA is that if she's breastfeeding, then it has to be postponed for at least 6 weeks before starting injection DMPA. And if she's not breastfeeding, even then it has to be postponed for at least 4 weeks, because preeclampsia itself is a high risk factor for venous thromboembolism, and DIMPA also increases the risk of VT slightly. So that is the option that we can give. Other options that we can give her is POPs, which can be started immediately after delivery. And if the option of implant is available, then that can also be offered to her. One important point about Zentchromin, usually it is given just after delivery to a woman. It is offered to them. But in cases of, in this case, particularly when the liver enzymes are deranged, ideally we should wait for the liver enzymes to come back to normal before we can offer her Zentchromin. So this is the package that we can give her.
Yeah, thank you. I think you beautifully summarized. The take-home message is that per se, hypertensive disorder, if a patient does not have chronic hypertension, does not preclude her for most of the effects of contraception, and she can essentially use the whole panel, as you had already said. But it's only if you have a hypertensive, then you have the restrictions on the use. That also for the combined hormone use. Yeah. So with that, I would hand over this stage to Dr. Jyotsna Suri ma'am for case 2.
Yeah, Garima, would you,
Yeah,
you
I'll
will be
do it,
moving
ma'am.
my slides.
Yes,
Yeah,
ma'am.
yeah. Thank you, Garima. So we move on to our next case. So this was a 28-year-old woman referred from another center. She came to us as a third gravida with previous 2 miscarriages, and she was only at 30 weeks pregnancy. She came with antepartum eclampsia in a post-ictal phase to us. And when she came, she was drowsy and disoriented. She had already had 3 episodes of GTCS at home and 2 episodes in the hospital from where she was referred to us. And over there, she had been given injection labetalol 40 milligram IV, loading dose of Maxal, loading dose of phenytoin, dexamethasone, and 2 units FFP. So there was no history of increased BP records in the past, and she was not on any medication previously. So next, please. Next slide. On admission, her general condition was poor. She was drowsy. Her BP was 170 by 110. Pulse was 86 per minute, and her saturation on room air was 98%. However, she had bilateral crepitations, and per abdomen, it was a 28-week size uterus. The uterus was relaxed. FHR was 132 beats per minute, and PV revealed a cervix 2 centimeters dilated, 30 to 40% effaced, with the membranes present and vertex at -3. So, Dr. Leena, this scenario comes to us. What is the provisional diagnosis, and how would you like to approach this case in the beginning? Immediately when she comes to us.
Yes, thank you, Dr. Jyotsna. Well, it's very, very clear that this is a case of antepartum eclampsia, and our patient has gone into pulmonary edema. So this is now a grave problem, because there's a very high risk of problems to the mother. So this we have to be very quick, and we have to act immediately. Thankfully, this patient was referred to you from a center which had carried out a lot of the very basic, what we call the ABCD of critical care management, which was good, because they had already started the patient on antihypertensive. They had already instituted the Maxal therapy, and then they had transferred the patient. This is a situation where we need to follow the principles of the ABCD of critical management, and teamwork and personal is extremely necessary for efficient management. So the first thing that we have to do is call for help, because the timely additional help is very essential for effective management. ABCD, that is airway, breathing, circulation, and the final D, which is of course delivery. So we would call for help. This would be followed by securing an airway. Put the patient in the lateral decubitus position, a mouth gag, neck extension, avoid injury to the mother, avoid tongue bite. Breathing, give her nasal oxygen and suction, use a pulse oximeter, make sure that her oxygen saturation is well above 95%. Circulation, have an IV access for her maternal resuscitation, send all her lab investigations, that is CBC, LFT, KFT, prothrombin time. Start by using crystalloids. You could use ringer lactate or enormal saline at about 80 ml per hour. Controlling the convulsions, well, you must give the loading dose and the maintenance dose. Catheterization is a must. We have to put in a Foley's catheter and measure the urine output. Controlling blood pressure with the appropriate use of, the antihypertensives. And steroids are important because now our patient has gone into pulmonary edema, and therefore we would be we would have to deliver her. So it is important that any gestational age less than 34 weeks, we should give corticosteroids. Another thing in this patient is Maxalt would be having a dual role. It also has a neuroprotective action, especially when we are going to be having a baby who's delivering less than 32 weeks. So in this case, that also becomes very important. This is the preliminary management that we would start before we plan the D part, which
Definitive
is the
management.
the delivery.
Yeah. Thank you, Dr. Leena. I think you have really summarized all the points by giving the ABCD. So that way we will not miss out anything. I think that was very beautifully addressed. So Dr. Devinder, 2 hours after she came to our hospital, her BP shot up to 180, 120, in spite of the injectable labetalol, which was also another shot was given in the hospital when she came. She had received 40 milligram already from the reference center. So what are the other choices we have for acute emergent hypertension and keeping in view her pulmonary edema? What would you like to give for such a patient?
Before I comment on the antihypertensive, I would try to emphasize, I would like to emphasize on this, that these type of patients should be kept in high dependency unit, or preferably the unit where ICU type of place where the positive pressure ventilation is available.
Thank you, Dr. Devinder. Yes, that was a very important point you have highlighted. Yeah.
Now, when we suspect that patient with the severe preeclampsia, or this patient, who has eclampsia and who has thrown fits, and she has only received 40 milligram of labetalol earlier, but she has not received the complete doses of this thing. But when we are also noticing that this case is complicated by pulmonary edema like symptoms, when we notice that chest is developing clefts. So I normally tell my PGs that, remember when ma'am said that ABCD, I want to extend that to LMNOP, where L stands for Lasix, M stands for morphine, N stands for nitroprusside here. But then with the pregnancy, we have to consider the vasodilator of a choice, that is hydralazine IV. Initially, hydralazine, we can give 5 milligram or 10 milligram over 2 minutes, and we can start the infusion of 1 milligram per ml at a 5 ml per hour rate, and try to maintain the blood pressure on that between systole means less than 140 or 130 to 140, and diastole between say 90, approximately like that, plus minus 100 up to 100, not more than that. So when I said Lasix, morphine, antihypertensive choice will be either labetalol injectable or hydralazine infusion. Then comes your oxygen, positive pressure ventilation, which has to be considered in these type of cases to have proper management. When it comes to the antihypertensive of choice, normally whenever we shift the patient to ICU, our anesthetist friend, they immediately shift them to nitroglycerin drip. Now the nitroglycerin definitely gives us better advantage, and BP comes down normal, but then we are also worried about the baby here. And in these type of cases, we think of as delivery as soon as possible, and she is antenatal. No doubt she is having 28 weeker with the 30 weeks gestation, 32 weeks of gestation, I think. What was the period of gestation in this? I forgot that.
This was a 32 weeks gestation.
At 28 weeks.
No, 30 weeks, sorry, 30-week gestation. Her per abdomen, it was 28 weeks.
So 28 weeks, approximately the baby weight I am expecting will be around 1 kg to 1.2 kilo for her. Though yes, it is, which was actually, it's coming approximately less than 3rd percentile, which has a very poor prognosis. This thing we have to keep in mind. Dexamethasone cover may give us help. So we may give a shot in saving the baby, because although it means it's 28 weeks, but it is more than 1 kilo, and every life we try to give them a shot, and we try to deliver them as soon as possible. You said the cervix was already 2 centimeter dilated, 30-40%. At my time, when I was PG, we would have done an ARM and we would have tried to deliver vaginally. But nowadays, nobody, they would have said that it's an early labor. They would have shifted to OT, because in OT, you get your anesthetist friend, and then immediately you also get the ICU facilities and other things. And this is the way actually these type of cases are managed in our referral center.
Yeah, so thank you, Dr. Devinder. So actually this patient was admitted in our obstetric critical care unit straight away as soon as she had come. And as our protocol, we do start in pulmonary edema, the nitroglycerine through the infusion pump. All our residents are very well trained, and we have never seen any problem with the babies. So we are giving it, and you know, for 24 hours, it's pretty safe. We start at a dose of 5 mics per minute.
I get to see the complication of methemoglobinemia in these type of cases.
Yeah.
So it is well
If we
documented
give long,
in literature.
yeah,
It is
yeah.
well documented.
Yes, no, if you give for a prolonged period, you know, more than 24 hours, then the complications are higher, plus the tachyphylaxis is also there.
Yes, you're
So
right.
just as intermediate, you know, because when the patient comes and with such a high BP and pulmonary edema, so to stabilize her, you know, this drug we have found very useful. And I mean, we have very good results with this. So most of the time by 25 mics per minute or so dose, you know, we get very good control. And of course, then we do shift over to the oral or to, you know, other drugs. In the meantime, we do the delivery also. So that is how we work here for the pulmonary edema.
Josna, can I just say something, Dr. Josna?
Yeah, Dr. Girja, definitely.
Yeah, see,
Please
basically, I feel that we had this patient, they very promptly send it to you at a very critical care center. That was excellent. But so many times we have such patients coming to us primarily, and we may not essentially have tertiary care centers. And therefore, using the 200 milligram labetalol tablet, if the patient is conscious, has been found to be quite effective as a transfer medicine. Because sometimes we are worried about giving nifedipine. So we can, and then rather than giving just a 40 milligram of labetalol and shifting the patient, it is better to give her a 200 milligrams of labetalol tablet. Even in your own triage or even in your practices, it can work till the time you're getting IV access and things like that. And there are quite a few wonderful observations and studies which have been made and experiences. Even I use it quite rampantly, and we found it very effective.
Yes.
So that can be considered to deliver it correctly and appropriately.
Definitely.
Injection Lasix not only reduces the preload, it also reduces, means it also brings down the blood pressure in such.
No, definitely. We do give Lasix also. Your LMN was absolutely, I think, very well summarized, Dr. Devinder. That is a very nice, you have given the, you know, the mnemonic for the pulmonary edema. So definitely Lasix is invaluable in such cases, but not primarily as an antihypertensive.
No, yeah, that's true.
Rather, yeah. So when this patient was investigated, we found that the first day when she had come on 8th of February, her we can see her CBC, her platelet count was 24,000, and her LFT was deranged. It was 11. The bilirubin was 11. Actually, that was a surprise for us because we didn't find her looking so icteric, you know, that she should be 11. Both her SGOT, PT were highly deranged. Her KFT was again deranged, correct was 1.4. And then when we repeated it on the next day, we found that the platelets were pretty much the same. The LFT had, you know, the bilirubin had become 6, but the enzymes remained to be deranged. In fact, they became worsened, and KFT from 1.4 went to 2.9, the creatinine. And PT INR, we can see that first day it was 2.1, second day it was 2.45, and LDH, the report we got on the 9th, it was 2,534. Ammonia levels also we had done. So because she had come with the drowsiness, even though it was post-ictal, but even after many hours, you know, she did not recover her GCS to 15. So we did do an ammonia level for her. So with this kind of situation, Dr. Girja, next please, Dr. Garima. So Dr. Girja, what things would you like to keep in mind, you know, with this kind of background with the investigations available?
She can be having hepatic encephalopathy. She, by the fact that she has eclampsia, she also has press. She must be having press because eclampsia is equivalent to press. And she also has HELLP as well as acute fatty liver of pregnancy can be the reason. Now, one more thing which I wanted to point out, Josna, I'm sorry for this, but I have seen in both the cases that LDH was not done sequentially, or even in this case, it was not done primarily on the first dated investigation. I think doing LDH definitely helps us in identifying these conditions earlier. We don't do it very frequently because it was not primarily a part of preeclampsia panel. But I feel that hemolysis, if you do not have access to schistocytes on PBS and all, LDH definitely helps us. And especially when the range is going beyond 800, then that is a good biomarker for serious risk assessment as far as the liver is concerned. So that is one observation I felt and a suggestion I wanted to make.
Yeah.
And now if you look at the ACOG 2020 guidelines, they have included LDH as a very valuable marker. Now in this particular patient, I would like to look at her from all these 3 points that I mentioned just now, because of her drowsiness and because of her extreme deranged LDH level. Because most commonly they are in favor of encephalopathy or FLP would be my attention.
Yeah.
I would like to do an hypoglycemia, random sugar.
Yeah. No, the sugars were normal. Sugars were normal. 156. Yeah. So Dr. Girja, your point is very well taken. LDH is something which we don't have in our emergency hours. So that is our, it's the reason why we were not able to do it the first day when she arrived. Second day it had gone to the routine lab. So this test is very, very important. We agree with you. And now coming to what you have said, we totally agree. So here we had a little bit of a conflict whether it is HELP or it is AFLP. Because of her very high LDH levels, we felt that, definitely hemolysis is something which was taking place and it could be HELP. But her enzyme, the bilirubin was very high. And second, that she had a DIC. Her INR was raised. So she, even though no clinical jaundice was there, but the second day also the bilirubin was 6. So can you go to the next slide, Garima? Garima, please, move the next slide. So next, please. So of course, whatever it was, whether it was HELP or whether it was AFLP, the plan was to deliver her, and for both of them, the answer is the delivery. So this is basically for the postgraduates. We have put the, the clinical clues to differentiate between the HELP, TTP, HUS, and AFLP. They are all having similar presentations when they come to us. So in this case, HELP and AFLP, both were something we were looking at. But normally in HELP, we do not have DIC. It's only seen in 10 to 20% cases, whereas in AFLP, DIC is a very, very prominent feature. And in our case, again, that was there. So next, please, next, Garima. When we did the Swansea, score for this patient, we found that 9 of the criteria were there for her, for the AFLP, which was, there is the study which showed that presence of 6 or more abnormal variables had a positive predictive value of 85% and negative predictive value of 100% for AFLP. So again, this was a point of contention. Anyway, we treated her as a AFLP oblique HELP syndrome. We were not sure until now. Also, we don't know for sure what it was. But keeping in mind that DIC, I think we were more in favor of AFLP. Okay, next, please.
Josna, I just wanted to add one more thing, that while we are doing obstetric scan in such patients, it's a good practice to do a scan in the epigastric region as well as the liver. Because now we have wonderful high resolution machines, we can do that.
Right. Yeah. So it's very good that even if you suspect it is HELP, you should always look for a subcapsular hematoma. And gallbladder edema is also something which a lot of studies are saying is associated with the preeclampsia. So I think, and many with the complications. So we should be looking for upper abdomen should never be missed. So Dr. Anjali, what are the various anticonvulsants? This patient had been given the magnesium sulfate loading dose from the referral center, and she came to us, and we also continued with the magnesium sulfate as per the Pritchard's regime. So later we found that her creatinine was high. So what would you recommend? What are the different regimes for magnesium sulfate for our postgraduates who are attending, and for specifically for the renal dysfunction, what would you recommend?
So there are various anticonvulsants available, but magnesium sulfate is the best because it decreases convulsions by at least half to two-thirds of the convulsions, and it is more effective than diazepam or phenytoin. Now, in this case, where both her liver metabolism and her renal functions are deranged, it was not a very easy choice, especially as her creatinine has risen to 2.9. So ideally, in the beginning, only the lady, if we had diagnosed it, we would have put her on a Zuspan regime, which is 4 gram loading dose and 1 to 2 gram per hour IV, ideally 1 gram, and monitored her extensively with every 4 to 6 hours. Her magnesium level should have been monitored. The other regimes available are Pritchard, Sibai, and Dhaka, but Zuspan fits this the best. And even in this case, till the around, because after 1.1 the levels are high, till 1.5 we can carry on giving with the loading dose and a maintenance dose. But after that, we can just give a loading dose, and the maintenance dose should not be given. Only we should check the magnesium level. This is because it is magnesium is excreted by the kidney, and if the levels rise, there are a lot of side effects, mainly due to its muscle relaxant action, which will affect her respiration, and may also cause cardiac toxicity at higher levels. So if the level comes to less than 8, it comes around 7, then only we can give another loading dose. Otherwise, we can withhold that also. In this case, particularly since her liver metabolism is also affected, even phenytoin and midazolam and the other anticonvulsants which are metabolized there should not be given. Her best chance is with Levera, and that too because it's excreted by the kidney. A renal dose should be given, which is 500 milligram BD.
Yeah, thank you, Dr. Anjali. I think you have covered all the points. So, recurrent seizure, this patient also had recurrent seizures. Even after her first loading dose, she had 2 more seizures. And therefore, when we found the patient, when she was sent to us, she was already receiving phenytoin also. From the referral center, they had started that. So, recurrent seizures is a very big problem in these severe cases. So here, as you have already pointed out, we can give her 1 more shot of 2 gram of magnesium sulfate with the recurrent seizure, and if it is not controlled, then we can go on for the other drugs like the diazepam or lorazepam and midazolam. But midazolam has got the advantage that it has got a short duration of action. So, if she's undelivered, it will not cause much of respiratory depression in the baby. And even for the mother, the respiratory depression is minimal. So we do prefer of these 3, the midazolam. But of course, nowadays, the levetiracetam is coming up in a big way. We have been using it in the cases in which we are not able to give the magnesium sulfate due to the renal dysfunction. So all our residents are very, very trained that if they have given the loading dose and before giving the next dose, they must have the creatinine level. So if it is more than 1.5, we do withhold it. The maintenance dose is withheld and the loading dose, and of course we send the magnesium levels to decide about the next doses. So next, Garima, can we go to the next, please? Yeah. So now Dr. Rinku, this patient has got organ dysfunction, her kidneys and her liver, her coagulation system, platelets, everything is deranged. So what are the principles of management of this case, keeping in mind all these problems? And especially we would like you to focus on the fluid management also for this patient.
Yeah, so thank you, ma'am. It seems that, I mean, she has a problem in almost every organ, so to say.
Yeah,
So,
absolutely. Yeah.
so I believe as we prepare for her delivery, she needs a urgent delivery. As I can see, she is in acute renal failure. Apart from that, I think the two things that we have to focus on, one is the ventilation and the fluid management. I think these are two things which are foremost in our mind, apart from the blood component therapy preparation, because she may need platelets, because she would probably have a normal delivery or whatever, and her, I think the latest count is only 22,000. So the focus, the main thing about the fluid is that we have to be very, very careful. Now she's having pulmonary edema also, so probably the fluid that we need to give her is I mean, we need a multidisciplinary management for this, and probably only 0 to 0.5 ml per hour per kg is what she needs at this moment.
Garima, can you change the slide, please? Yeah, please, Dr.
Yeah,
Rinku, carry on.
yeah. So, and apart from that, the other thing is that, we need to see what kind of fluid we are giving her. We have to be very, very careful about the fluid. We need to involve the nephrologist. She's in acute renal failure. She would probably need a renal replacement soon. So that is again one aspect that we have to focus on at the moment.
Yeah. So thank you, Dr. Rinku. Yeah, please, next slide. So the fluids, as you said, the crystalloid, sodium chloride or ringer lactate are the fluids which we normally give, and we avoid the high water concentration, the 5DW, which is the dextrose water. So they actually are become hypotonic, and as soon as they are inside the body, the dextrose is metabolized. So this can actually go into the cells and cause cellular edema. So these fluids, dextrose containing fluids, we don't give. And the NICE guidelines also, they specifically say that do not preload women who have severe preeclampsia with IV fluids before establishing the low dose epidural analgesia or combined spinal epidural analgesia. And do not use volume expansion in the women with preeclampsia unless hydralazine is the antenatal antihypertensive which is being used. And as you pointed out, no fluids more than 80 ml per hour unless there are other ongoing fluid losses. For example, she's hemorrhaging, she's having a abruption or something else. So we would be very, very conservative about giving the fluid to such a patient. Yeah, next, please. Yeah, next. Garima, next, please. Yeah, so Dr. Shruti, what is the obstetric management? So we have discussed about all the things which, the stabilization, her anticonvulsants, antihypertensives, and her general critical care management. But now that, the final point is that we have to deliver her. So how would you like to deliver her, and what kind of precautions you would like to take over here for this case?
Yes, ma'am. So she's a case of eclampsia with pulmonary edema, with HELP, with probably FLP, with DIC. So a lot of complications. So no rule of expectant management. We have to deliver her fast, and delivery should occur within like 6 to 8 hours at least. So the mode of delivery is decided by many factors, like she's a multigravida at 30 weeks with normal fetal heart right now. She has a favorable PV finding. And the fact that she's in DIC again precludes a surgical intervention at the moment. So all this, because of all this, I will go for a trial of vaginal delivery for this patient. And special precaution that we have to take is, first of all, a proper counseling of the relatives with regards to the maternal condition, and the neonatal outcome is very important, and consent for induction, because in a preterm baby we are inducing. So that has to be taken. Apart from that, all the measures that were being taken to stabilize the patient should continue throughout the labor. The patient should be in HDU and ICU setup. She should be kept in because she's having a recurrent seizure, she should be in a bed with a railing, which is usually padded. And she should be kept in a left lateral position with oxygen by mask. And maternal induction should be started with after stabilization. The induction can be started with the dual agent, like we can start with tab misoprostol, 25 micrograms per vaginal. This can be accompanied with intracervical Foley's catheter, where the balloon can be inflated with around 40 to 50 cc of saline. So this reduces the induction to the establishment of labor duration. Apart from that, we can also induce the labor by using a concentrated syntocinon and repeat the PV after 3 to 4 hours. So apart from this, maternal monitoring and fetal monitoring should also go hand in hand. Maternal monitoring will include her pulse, BP, respiratory rate, SpO2 monitoring, intermittent chest auscultation. Everything should be done every half an hourly because she's very high risk. Input-output charting every hourly. If she's on Maxil, then that's a different story. But because she has been put on some other anti-epileptic or some other prophylaxis, so that need not be done. But strict input-output charting has to be hourly. And then we have to monitor the labor by plotting a partograph to see if she's progressing well or not. Another important point is because she's in DIC, we have to tackle this problem of thrombocytopenia and the coagulopathy. But the fact is that because the platelet is being destroyed, if we give the platelets when she's not in labor, it will again be destroyed and it will be of no use to the patient. So what the idea is that we should give platelet transfusion, particularly more useful would be SDP, 1 unit of SDP or 4 to 6 random donor platelets should be transfused at the time of active labor or at the time when she is about to deliver, because platelets increase within 10 minutes of transfusion and it will be most effective during that time. Also, the coagulopathy has to be corrected. So this can be done by either giving fresh frozen plasma. So the dose is around 12 to 15 milliliters per kg of body weight. Again, very judicious use. We can add Lasix whenever we are giving these blood products to correct the coagulopathy. This has to be given again when she is in established labor, not to overload her. And around 2 to 4 units will be enough. Again, to circumvent this FFP, the overloading by FFP, we can even give cryoprecipitates, 10 units. That will also correct the coagulopathy with lesser volume of the blood product. So once this has been done, and if the patient becomes fully dilated, we have to, during labor, we have to also anticipate that she might bleed anytime. So we have to keep a watch for vaginal bleeding, any occurrence of like abruption and all in her, that has to be seen and managed accordingly. Apart from that, if she becomes fully dilated, then because this patient seems to be has a poor GCS, she might not be able to bear down. We can use forceps delivery, like on instrumental vaginal delivery in this case, particularly forceps. Vacuum should not be used because it's a preterm baby. And once the baby is delivered, we can give Lasix because she was in pulmonary edema. A prophylactic Lasix of 20 or 40 milligrams can be given to the woman, to the lady, IV. Just after the delivery of the baby. Apart from that, we have to be very careful that while we are delivering the baby, it is better to give a episiotomy rather than allowing a perineal tear to happen, because she has high risk of traumatic as well as atonic PPH. So a good perineal support, giving an episiotomy is better in this patient. After that, if we should anticipate atonic PPH in this patient, so keep a condom catheter ready. Active management of third stage has to be done in this patient aggressively, and that is all, ma'am, I think.
Yeah, thank you, Shruti. You have really wonderfully put across the entire obstetric management in few lines. And I must say that the two most important things which you said, first was that don't transfuse the platelets until she goes into active stage of labor. So that is something we want to stress, that don't waste those precious resources. The platelets will be destroyed. So we also advocate that once she's in active labor, say about 7-8 centimeters, then only you transfuse the platelet. Second is be very careful about her during her delivery. So only the senior resident or a senior person should be taking the delivery. Such cases, there is so much of risk of having a hematoma. So be very careful about that. So that is very, very important. And arrange all your products. You have to, you are dealing with something which can actually lead to a very, very serious situation. So we want to anticipate all these problems and arrange our blood and blood products so that we have a good outcome for this patient. So luckily for us, the patient had delivered. We had induced her, rather augmented her with the oxytocin, and she delivered a live baby of about 1.2 kg. The baby had gone to nursery. Unfortunately, the baby did not survive after 3 days, but the mother made it and she has gone home now. So it was a very, very challenging case. Okay, Garima, I think we can go to the last slide, the take-home message, and we can be, I think, then finish this panel for today. So we can discuss just small key points that preeclampsia is a multi-system disorder which can affect all the organ systems, and the key principles in managing patients with preeclampsia are treatment of severe hypertension, seizure prevention, timely delivery, and postpartum surveillance. The definitive treatment of preeclampsia is delivery to prevent development of maternal or fetal complications from disease progression. Timing of delivery is based upon gestational age, severity of preeclampsia, and maternal and fetal condition. Next, please. Preeclampsia with features of severe disease is generally regarded as an indication for delivery, regardless of gestational age. However, prolonging antepartum management in a tertiary care or in consultation with a maternal fetal medicine specialist is an option for selected patients remote from term. Maxelf is the drug of choice for preventing seizures, and the maintenance dose should always be adjusted according to the renal function, even though loading dose can be given safely. Fluid balance should be monitored closely to avoid excessive administration, because pulmonary edema is the leading cause of mortality in preeclampsia. So a maintenance infusion of a balanced salt or isotonic saline of not more than 80 ml per hour is often adequate to prevent acute, to prevent the kidney injury as well as to prevent the pulmonary edema. So I think that's where we end, and we look upon Dr. Suchitra's comments and expert, opinion about these cases, and any value added comments we are looking forward for, Madam.
It was excellently all the technical issues, and I think because of the different cases, you've been able to get to what are the do's and the don'ts. So I think that is very important. What I'd like to say over here is, if I'm just doing a summing up, in the low resource setups, the gestosis score is very, very useful. Wherever it's possible, yes, you have the first trimester screening and the wonderful biomarkers and whatever you want to do, any of those. But otherwise, in the low resource setting, the gestosis score, if it is and above that, please use low dose aspirin as well as calcium. Second is the measurement of BP. I would think is a very, very key thing in a busy antenatal OPD, particularly obese patients and thin patients. You can end up having wrong BP measurements. So therefore, that BP cuff is very essential. And wherever we find that this patient is a high risk, please put a red tag to her and make sure that she comes for vigilance. One more thing I'd like to add is, all the antihypertensives, one of the new drugs which has entered our armamentarium is nicardipine. It was used only by the cardiologists earlier, into our armamentarium. So you can use the non-severe as well as a severe variety of HDP. And the titral dose, it is exactly like nifedipine, but it is titrable. So even an IV dose can be used as a 10 and a 25 milligrams vial. So you can dilute it in 250 ml of normal and 0.1 ml per hour, and you can titrate the dose. So that is what I wanted to add. But otherwise, I think I've wonderfully covered up where you can exactly use nitroprusside. And I think that fluid management slide was very, very important. The tendency is to give more of fluids without monitoring. So be very, very careful. I think that fluid management, I was very, very happy that you put up that slide. And what I'd also like to say is the management of blood pressure. Many a times what happens is, in bigger hospitals, you can involve even a hematologist. Sometimes when you want to decide how much you want to give, of course, as postgraduate residents in busy labor wards, what is a calculation and how much you have to give. But remember, there is always a blood transfusion department in big hospitals and a hematologist. So you can take help of those people. And there was a question which somebody had put up in the chat. What happens post-delivery? Important to monitor these patients, because if they've had high blood pressure, you have to keep them in for a longer time. If they've had severe preeclampsia, you have to monitor and try to titrate the doses. Sometimes the BP can shoot up even in the post period. And very, very important is, these women have to be called back for a follow-up. If there is a persistence of hypertension, make sure that you have looked at what is the cause. Was it a kidney related cause? Was it a cardiac related cause? Was the patient obese? Try to find out the cause and try to follow her up and counsel them. Contraception we have discussed very nicely, but counsel these women for lifestyle changes, and they should not get pregnant at least for the next 2 years, 3 years. And if they have to get pregnant, they should come for preconception counseling. And another important thing which I'd like to say is, today there's a lot of research which is showing that once it's a preeclampsia, it's going to be with you for life, meaning there are going to be those changes. So this patient might be a future cardiovascular or a diabetic, because ultimately it's all related to gestosis. So my dear postgraduates and all my dear colleagues, make sure you monitor your patients very, very well. And of course, having said that, there are so many technical small little things, the importance of an HDU, importance of an ICU. I think we have discussed that very nicely. I think Devendra also brought out those issues, and all the panelists have done a wonderful job. And Prakash Mehta's talk was absolutely amazing. So I think those things we should definitely make sure that we have monitored. And of course, ultrasound related, most of the bigger hospitals will have fetal monitoring also. So we are able to take care and, when to exactly deliver, what time, because you don't want to have a stillbirth. What you want to prevent is a stillbirth. So try to be very, very vigilant exactly when you want to deliver. And of course, Girija has brought out one very nice point that ultrasound, arterial guidance for fusion is also important. There are critical cases where, if you want to measure exactly what are the cardiac pressures and how much of fluid to be given, I think those arterial lines also are very, very helpful. And thank you once again. Thanks to all of you. Thanks to Dr. Achla once again. And, for giving us this opportunity. And Jyotsna, you conducted this very beautifully. Very, very.
Thank you, ma'am. Thank you so much for such wonderful points which you have highlighted to all of us. And we really want to congratulate you and Dr. Girija for developing that beautiful score, which is, I think, India's own, and it is going to be, used in all the countries. I'm sure it is going to come up in the future in a really big way. And we all would like to, as you have suggested, to download that on our phones and use it in our OPD freely. So thank you so much. And we wish you and Dr. Girija all the best for the, upcoming posts for both of you. And we are sure you would be both there where you actually deserve to be. Yeah.
Just ensure that everybody should, check there on the FOGSI portal, just check your mobile number and whether everything is registered correctly. You're a category member, because then you're allowed to vote. And please vote for the week of March.
Yes, ma'am, definitely. Dr. Monica? Yeah. Monica, you
Dr.
over to you now.
And Dr. Girija, I think I felt greetings for you and best wishes that the aim which you have should be fulfilled. And our sincere thanks to Dr. Prakash Mehta. It was a treat and mesmerizing talk. It was wonderful.
Thank you, ma'am. Thank you so much.
Absolutely. Thank you, Sharda, ma'am.
Absolutely.
And
Thank
just
you,
before
ma'am.
I propose my vote of thanks, I would like Dr. Pratima to please speak a few words, because she had lost the internet connection and now she has joined us back. So she would like to. Ma'am, please unmute.
Thank you, Monica. I think it was such a, such an academic bonanza today that I'm really, mesmerized by the talk of Dr. Mehta and the panel discussion. They have discussed mild cases, severe cases, and critical cases. Really, really very good. And I really like the idea Dr. Has pointed out about use of knee cardia. I think we have been using it now. We have started using it, and I have seen that we can go up to 30 milligram BD. We have gone in one case, and it has really worked. So even early pregnancy, we are started using this, because this can be given IV, and besides the labetalol, we can add this now. And second thing is the talk of biomarker. I think we have to, make it a habit now to do SFILT and PLBI, just so that we can really, predict the complications. So I think both the talks were very good. The panel was excellent, and I learned a lot.
Thank you, ma'am. As regards quick queries from the audience, there's one question which I've kind of compiled for Dr. Prakash is any role of ophthalmic artery Doppler, Congo red dye test, or maternal 2D echo in prediction of preeclampsia, sir? Very quickly.
Yeah, these tests are being used as an experimental basis for a prediction of preeclampsia. Work is going on, but I don't think we have the last word yet. They have to be done only in the research setting. You cannot use it on the general population.
And as regards any range of mean arterial pressure to be maintained in preeclampsia?
See, basically, while we get mean arterial pressure on most of our monitors, I think for people who are not used to, the critical care kind of setups, we can still go. It will be simpler for them to remember the systolic and the diastolic blood pressure. Now, our main worry for the blood pressure is that it should not cause a cranial issue. And also press is another very important thing that could occur. Once the BP shoots up beyond 180, 120, the chance of press becomes very high. That is the posterior reversible encephalopathy syndrome. So that becomes very high, and that could lead to alteration in the GCS scores. So that we need to keep in mind, but make sure you don't have to bring down the blood pressure too much to never normalize the blood pressure, because if you normalize the blood pressure so much, then the fetus is going to suffer. So as long as the fetus is inside, I generally tend to keep the blood pressure to around 100 by 160. Systolic around 160, diastolic around 100. That is the kind of pressures I keep looking at. Because quite often when you have a case like this, you cannot control the blood pressure. I've had patients with 200, 140, 200, 160. It just doesn't get controlled. So best thing I would do is I would deliver the patient immediately.
Thank you, sir. And Suchitra ma'am, a word about dose of Nicardia. You mentioned the newer drug.
Yeah, so Nicardia is available as oral as well as an IV dose. Now the IV is available as a 10 milligram vial or a 25 milligrams vial that can be diluted in about 250 ml of normal saline and to get the optimal blood pressure. So usually in a span of 30 to 35 minutes, you can gradually start increasing the dose to get the optimal levels. It's soluble, it's water soluble, unlike nifedipine. And the oral dose is of course available. So oral dose can be used the same way as using a nifedipine dose. But in an IV situation, the nicardipine IV plays big role.
Thank you. And Jyotsna ma'am, ideal antihypertensive to be used in the postnatal period. That's the last query.
Yeah, ideal. Oh my God, that, normally what we people do is, because in the pregnancy, it is levotalol always. And if we have to give a second antihypertensive, we add nifedipine. In postpartum period, we normally switch over to either amlodipine, because amlodipine is safe in the postpartum women, and the milk secretion is also not known to have any, it's a very small secretion in the milk. And if we have to add another, we normally add the metoprolol. So, and even the ACE inhibitors can be added in the postpartum, especially the enalapril has been seen not to have a significant excretion in the milk. So all these drugs in the postpartum period, we have a wider choice. We can use many of the drugs. Of course, with methyl dopa, there is a risk of the postpartum depression, but nowadays that drug is hardly available. I really don't know why. Ma'am, Suchitra ma'am, what is the reason why we are being deprived of such a good drug, which has, for chronic hypertension, it was so useful. I don't know why it is out of the market.
Talks up the production cost and the price.
Pharma driven.
It's very sad for our patients actually.
That's exactly what happened with HCQS also. Na? Everything is manipulated by the market.
On that note, I guess all the queries of audience which were put in the chat box have been answered. And I'm sure all.
One more thing, Monica, about antihypertensives, I wanted to add one more thing. We always look for, we don't need to always give those immediate acting nifedipine. There are 3 types of preparation: the immediate acting, the intermediate acting, which is available as the nifedipine retard in India, and then the third is the extended release, or the XL form. So there is in the ACOG guidelines, because it is always written as the immediate release. So our students will always say we have to give only the immediate release and not the retard preparation, which is actually not, I think, the correct thing. So for immediate release, it's not available very easily in the market, because immediate release tablets are very, I don't know whether it is pharma driven or what is the reason. It is the retard which is easily available. And only thing is, it takes little more time for the action to start, because immediate release action starts within 10 to 10 minutes. And the other one, the action starts in 30 to 45 minutes. So we don't really, unless that there is some very, very emergent condition that you give IV, otherwise we can easily give the retard preparation also. It is very useful and we are using it with great efficacy. So there's no problem. Please use the retard preparation, which is available in our country freely. That is the other thing which I wanted to tell in this today.
One quick comment on aspirin dose, ma'am. People had asked and probably have already been answered by Garima and earlier as well, that aspirin dosage has to be 150 if the gestosis prediction score is high. Even if the uterine RT Doppler are showing you changes and they are predictive of the dangerous signs, and of course if the weight is more, so then aspirin doses has to be 150, no doubt about 150. That. Else there is a practice of giving 75 still. So this was another query. And last question is hydralazine available?
Not
limited again. Limited again.
It's not in Delhi. Not in Delhi.
It's not easily available, but I've used it quite often. The biggest advantage, like what Dr. Jyotsna said, nifedipine works very, very well. That's my drug of choice. Whenever the blood pressure is very high, I give it. And if the patient is unconscious or the GCS is very poor, she's unable to swallow, I put in a Ryle's tube and given nifedipine through the Ryle's tube. It does work.
Any strategies for risk modulation near term, Suchitra ma'am?
I think when we are talking of risk strategies, we have to actually start doing it right at the beginning. We are talking of prevention of preeclampsia. And following what Dr. Prakash said, I think that women who are to start talking of using split by the PGLF ratio, so that we know which patients can carry on, which patients are to develop more of complications, then where we can sit tight. I think this we've actually the entire lecture which Prakash gave, which carried all the risk strategies. So
thank you, ma'am.
What I would follow definitely.
Monica, time to wind up, bhai.
Yes, ma'am. I'm just inviting Dr. Achla to speak last first. Okay, it was so interesting. Everybody kept engrossed.
Doctor, with Suchitra around, it will never ending talk.
Yeah, I think
he has answers to everything.
Yeah. Yes, madam. I think it has been a very good session with Dr. Prakash Mehta, Dr. Suchitra, Dr. Girija, Jyotsna, and all the Garima and all the panelists giving very good inputs. And I think there are few things which we think, that everybody knows, but there are these small nuances which everybody doesn't know, especially like things like we avoid labetalol in pulmonary edema, and the renal doses for Maxelf, which everybody should know, instead of, and that first dose can be given and then you can titrate. Another thing I wanted to add, when convulsions are occurring and you don't have a line, or if you don't have injection facilities, sometimes, even the best drug for recurrent convulsion is midazolam, and it can be even given nasally, just open the ampule and put it in the nose. It is as effective as parenteral compose or midazolam. So I think we've had a good session, and now everybody is waiting to wind it up. So thank you, everyone. And
Thank you so much.
Best of luck to all the people who are, standing for the elections to AOGD, FOGSI, and we wish everybody good luck.
Thank you so much.
Dr.
Thank you.
Suchitra, Dr. Girija, both of you.
Thank you. Thanks, Atan.
Thank you.
Thank you so much.
Thank you, everybody. Good night.
Thank you. Thank you
Good
so
night.
All
much.
the best, Girija and Suchitra. All the best.
Thank you.
All the best.
All the
Good
best.
night.
But Dr. Mehta, your lecture was a treat today.
Thank you, ma'am. Any number of praises are not equal to one word from you. That makes me very happy.
Best of luck to everybody.
Thank you.